Okay. All right. Good morning. I call this hybrid oversight roundtable to order. Today is Wednesday, November 5th, 2025. The time is 10 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health, and we're calling this roundtable on the Department of Behavioral Health, or DBH, as comprehensive plan for the school-based behavioral health program. In fiscal year 2026, the Budget Support Act, there was a subtitle included called the School-Based Behavioral Health Program Strengthening Amendment Act of 2025, which required DBH to develop a comprehensive plan to strengthen the school-based behavioral health program model. The key objectives for the plan were to, one, assess the effectiveness of the existing model of service delivery. Two, determine the services and availability in each school through analysis of data from the environmental scan completed during the 24-25 school year. Three, develop models of care to support schools based on service needs. And four, establish criteria for assignment of staff resources to each school based on needs. The purpose of today's roundtable is to review and discuss DBH's plan and understand how DBH moves forward with its new comprehensive plan to transition to a program from a mixed model that includes community-based organizations partnering to provide services to one that primarily is staffed by in-house DBH clinicians. For years, this committee and the council have championed investments to ensure that every student in the district has access to timely, high-quality mental health support in their school. We have heard repeatedly from teachers, parents, students, and providers that behavioral health is not a nice to have, but a core component of what makes learning possible. Yet the program continues to face challenges in maintaining full coverage across all public and public charter schools, achieving equitable access and delivering consistency that our students and school communities deserve. DBH's new plan marks, a major shift, moving from a one-size-fits-all model to a needs-based approach with the goal of bringing most services in-house. While this shift could offer greater consistency and accountability, it also raises important questions about transparency and capacity, continuity of care, stakeholder engagement, and the future role of community partners. We're here today to examine how DBH intends to operationalize this plan, including how decisions are being made about staffing, budget allocations, and timelines, what metrics will be used to measure progress, and most importantly, how these changes will impact students and families. In reviewing the plan, I found while it describes promising principles, it does leave some implementation details largely unresolved. There's limited transparency on the budget for future school years. Gaps remain in terms of explaining how student and caregiver access will actually improve. The plan critiques community partners' billing and performance without acknowledging DBH's own systemic barriers and challenges. And the process of transitioning away from CBOs lacks a clear roadmap in terms of stakeholder communication and engagement. Today, our goal is to understand what's working, what's not, and what must change to ensure that every student, regardless of their insurance type or income, disability, or school type, has access to the behavioral health supports that they need to learn, grow, and thrive. We hope that DBH is genuinely listening. They are here, and we'll use this feedback and insights shared today as we move forward. We are concerned, however, that this process is sort of being seen as just a procedural checkbox as opposed to something that is actually going to shift the status quo. So now we're going to turn to our public witnesses. If any of my colleagues join, I'll certainly join to them as well. All of our public witnesses, I love you, but you have 3 minutes to testify. That's a lot to get out. So, of course, we'll have your written testimony for the record. It's not because we don't enjoy you, but there are a lot of people who want to testify today, and we want to make space for all of those folks to be able to do so. So I have 4 chairs here: Kimberly Harrington, Orron Gann, Christian Harris, and Parrett Arrington. Okay, Kimberly, when you're ready.
Good morning. Thank you, Councilmember Henderson, for the opportunity to share my testimony about DBH's school behavioral health
Okay,
program.
you're gonna have to lean into the mic, pull it closer. It's okay.
My name is Kimberly Harrington, and I am a longtime DC resident in Ward 4 and a 20-year employee of DC government. I'm a clinical social worker, a registered play therapist, and a member and delegate of 1199 SEIU United Healthcare Workers East. I work for DBH's School Behavioral Health Program and am placed at Stuart Hobson Middle School in Ward 6. I've been with DBH and at Stuart Hobson for 10 years. In my role, I provide prevention, intervention, and treatment services. As a member of the school's mental health team, I collaborate with the school in determining which programs and what focus those services should be. Prevention programming includes signs of suicide, a suicide prevention program, a new youth mental health advisory board, and an after-school club I started in 2020 called Craft and Chat. My intervention programming includes small groups of students who are identified as needing additional Tier 2 support. This year, we saw a significant increase in anxiety and grief, as well as the number of students in need. So I'm now doing 2 concurrent groups with that focus. I provide individual therapy and reach a minimum caseload of 15 by December 1st each year. These students are referred to therapy by teachers, parents, school staff, and themselves. Prevention programming helps to identify the needs of the students and specific students needing more support. I'd like to share my experience with the Signs of Suicide program. I hope this also highlights the mental health crisis facing youth at this time. According to 2023 data provided by the American Federation for Suicide Prevention, suicide is the 4th leading cause of death in youth 15 to 24. Data from the 2021 Youth Risk and Behavior Survey shows that 8.3% of male middle school students and 17% of female middle school students have ever tried to kill themselves. 18.2% of male and 36.9% of female students have ever seriously considered thoughts of suicide. Our mental health team provides school-wide suicide prevention using the MindWise curriculum provided by OSSI. 7 members of our team, with the support of 2 DBH colleagues, facilitated 28 programs, presentations to students. During a 3-week period, we facilitated this program. We met with 160 students for one-on-one conversations and had 58 parent contacts. I was in daily communication with my supervisor to review the risk assessment and safety planning. What we found, our students are struggling. They're struggling with the stress and anxiety around the need to perform to get into a good school, the ongoing fear of school and community violence. They're also dealing with the presence of both military and federal law enforcement agents who are carrying out targeted and violent apprehensions of community members. I've read and I support the School Behavioral Health Program Comprehensive Plan. Consistent with the report's findings, the long experience of DBH's School Behavioral Health Program has supported me through clinical supervision, team support, the knowledge and wisdom of my supervisor and branch chief. DBH has proven that it can hire and retain clinicians. By converting the phased-out CBO positions to DBH ones, it will be possible to ensure all schools in DC have a clinician placed in them to support students in the school community. Thank you again for this opportunity to testify and your continued support of our program.
Thank you. Mr. Gann? You got to turn your mic on.
Oh,
There you go.
yeah, it's important. Good morning. My name is Dr. Ron Gan, and I'm a clinical psychologist. I served as a DBH school behavioral health clinician since September 2004. I'm here to share my strong belief that the school behavioral health services in the city should be expanded by the DBH school behavioral health program. And let me share some about my personal experience. I believe there are 2 main reasons for my longevity in this role. The first is the commitment to the mission of providing access to mental health services to every child that needs it. Over my career in the DBH school-based program, I was available to support children at their most difficult times. A 7-year-old girl that lost her dad as a result of violence in the community was able to start working with me a day or 2 later. We met before the family went to view the body, before the funeral, and after the funeral. We continued to work until the child reported she discovered her new happy self, feel like she got a chance to say goodbye to her father and was ready to say healthy goodbye to me. I work with a 6-year-old boy with history of severe neglect, abuse, and displacement from home. In our several years of working together, the child was able to develop healthy attachments with caretakers and work through some of his traumatic memories. Our clinical work at school could be taxing and it takes its toll. But most of the time, it's also felt like a privilege to do work that matters and to be part of an organization that does its job. And this is the second reason I still enjoy doing my job after all this year. It is the DBH School Behavioral Health Program. As part of the DBH program, I always felt that I have the support I need when I need it. For example, ongoing supervision and consultation in group and individually are part of the way we perform. We perform our job and get better at it. It is not just a way, it's not just a way to work toward licensing requirement. Moreover, being part of a network of dozens of seasoned clinicians and supervisors is very empowering experience and useful because we collaborate as a team. All this would not be possible without strong leadership that came from within the program and knows from experience what it is to be clinician in a school. While some of the names may change over the years, the strong principle and the high standard stay the same or even evolve to meet with new needs and challenges. This is why I call for the city to finally fully utilize the DBH School Behavioral Health Program in this overdue expansion.
Thank you. Mr. Harris.
Good morning, Chairwoman Henderson and members of the Committee on Health. Thank you for the opportunity to testify. My name is Christian Harris, and I'm a clinical social worker for the Department of Behavioral Health at Kelly Miller Middle School. I've been in this role for close to 2 years and previously worked at Ballou High School. I am also a member of 1199 SEIU, the largest healthcare workers union in the country. In my time at DBH, I've heard directly from many teachers that our support as mental health professionals goes a long way. We know, and teachers know, that mental health is an integral part of learning and child development. During my first full year as a social worker at a DCPS school, I noticed that many of our students are struggling with their relationship with their families. To put it plainly, they have a lot going on. In my role, students come to me to express themselves and talk openly in a way that they might not be able to do with other people in their lives. DBH staff holds a wealth of institutional knowledge, and we have an array of resources at our disposal. We offer trainings and have a designated crisis response team. It is because of this infrastructure that we are able to meet the needs of our community. I'm concerned about the future of vulnerable and oppressed families in our city if we separate this team of people who work with our students. As an employee of DBH in DC Public Schools, I find that many community members do not understand that I have limited access to student records and report cards that help to inform my work. If I was not an employee of the DC government and was further removed from DBH, it would become significantly harder for me to offer the support that families need. When I first came to DC from Baltimore, I was amazed that the city government was able to provide a service like the school-based behavioral health program. Its existence demonstrates that DC takes our children's mental health seriously, and its continued existence is necessary for our students to thrive. I have read and I support the School Behavioral Health Program Comprehensive Plan. DBH has demonstrated that the clinicians that we work with have a desire to be in the schools for years at a time and serve as a resource for students and the school communities. Thank you again for your time and for continuing to support the school-based behavioral health program.
Thank you. Ms. Arrington.
Good morning, Councilmember Henderson. Thank you for the opportunity to speak today about the School Behavioral Health Program, a program that has been serving district students and families for more than 20 years. I've had the honor of serving as a school-based clinical psychologist for the past 17 years. I'm at Jackson Reed High School, and I've been there for 14 years. I want to begin by stating that I have read and fully support the School Behavioral Health Program's comprehensive plan. It reflects the values, structure, and commitment to quality that have guided this program for over 2 decades. There has been concern voiced by some community-based organizations that if they are phased out, schools will lose clinicians. The truth is that, yes, CBO clinicians would transition out of certain schools, but DBH clinicians will be placed in those schools to ensure continuity of care. There will be a transition period, but ultimately this shift will mean that more schools will have clinicians, not fewer, because DBH has demonstrated stronger hiring and retention capacity. Additionally, the quality and consistency of services will continue to improve. DBH's internal structures provides exemplary supervision, rigorous quality control, and accountability, ensuring that every child receives compassionate, evidence-based care from experienced clinicians who are supported and guided by strong clinical leadership. This program is not a training ground for inexperienced clinicians. It is a professional, mission-driven program staffed by well-vetted, seasoned clinicians who are passionate about this work and understand its gravity. We serve students who are among the most vulnerable, those experiencing trauma, instability, and emotional distress. The structure within DBH enables us to maintain the highest standards of care, ensuring that quality is never sacrificed for convenience. Yes, our work is challenging, but it is deeply meaningful, and we are able to do it well because of the supervision, professional development, and collaboration that DBH provides. That foundation is why this program has succeeded for more than 20 years and why it must remain intact. As the council considers the path forward, I urge you to ensure that the school behavioral health program remains within the Department of Behavioral Health, where its structure, supervision, and accountability are already in place, and that it be allowed to expand through the direct hiring of full-time DBH school-based clinicians. This approach will preserve the program's integrity while expanding its reach, enabling more students and families to access the high-quality services they deserve. Preserving its home within DBH while expanding its impact will ensure that the school behavioral health program remains one of district's most effective, compassionate, and enduring supports for children and families. Thank you so much for your time.
Thank you. Thank you to this panel of witnesses, and I recognize that this could be a little bit awkward as you're sitting a couple of feet from your boss. But I do want to ask some questions in terms of sort of the creation of this plan. And I think for most people in the room, but just for additional context for folks, like the committee was prepared to transition this program from DBH to DC Health. And part of that was DC Health has a lot of already school-based programs in the health space because they run the health centers, they have the school nurse program, et cetera. But also feeling like there needed to be a different type of structure and was unclear of whether or not DBH wanted to deliver on that. We decided to pause on that in part due to the advocacy from some of the DBH clinicians who frankly were more convincing in terms of their ability to deliver this program if given the opportunity because of the work that was already being done. So I'm curious, as in the creation of this comprehensive plan, what involvement, if any, did you all have in the creation of it, given many of you have had very long tenures serving as clinicians in schools?
I can start to address that. I think one of the tricky things is with the expansion differentiating between DBH School Behavioral Health Program and the collection of community-based organizations. I firmly believe, and I think we heard today, and I think my DBH colleagues would agree, that the services that DBH School Behavioral Health Program have been providing are quality, consistent, long-term services. In terms of this plan, one, I can say, I am in constant contact with my supervisor and branch chief. They hear from me all the time. So I trust that our internal chain of command hears from us and passes on the important information to the higher ups, and that is taken into account. Also, additionally, there were focus groups facilitated this summer with both DBH clinicians and CBOs. And so just in terms of like what I said about the chain of command, there is open dialogue within our program, and I trust that our leadership takes that to the next level so that that can be incorporated into the creation of programs, plans like this.
Okay. So in terms of the focus groups that occurred over the summer, these were in-person conversations or virtual or?
Virtual?
I believe they were all virtual.
How many?
I think we had one
Okay.
that I participated, but I know that they did several of them, and I participated in one.
Okay, so this would, the plan would mark a very large expansion in terms of the number of DBH clinicians and require an extensive amount of hiring to be able to fill those particular vacancies. And we're talking like 57 new people. In terms of your experience, now there were already some vacancies that were available on the team, but the ability to recruit. One of the things we often hear from CBOs, and not just those who are involved in the school-based space, but just overall for individuals who are looking for clinicians, social workers, et cetera, is, oh, we can't find folks. Oh, there's a lot of people who are working in private practice and doing those different things. What makes this working for DBH different? Like, why should we feel more confident that that is a better plan to deliver on in terms of recruitment and retention?
I mean, I have heard and read about the nationwide shortage of mental health professionals. I think there is a subset of people who do not want to work in person anymore or never did. Of the people remaining who do want to work in person, there are a variety of options. I think DBH is a strong contender because of everything we addressed in terms of, like, if you're going to the school-based program, this is not a new fledgling program. They know what they're doing. You come in, you're provided the immediate support, the on-the-job training, and the ongoing support you need. There are many advantages to being a District of Columbia employee, to include the package, the benefits package, which not just is an attractive package, but also provides, again, the support to make a fair wage for the work that we do. I think once someone goes through the interview process, they would meet our staff and understand the type of support that they would receive. And certainly, there would now be a lot of clinicians who have that experience working in the schools who would have the opportunity to apply for the positions within DBH and determine on their own if this is something that they want to do, the employer that they want.
Okay. So there's a shift in terms of the model, what is being proposed, right? So right now it is one clinician for every school. We haven't been able to accomplish that, but that is nonetheless what our model is. Now, I was surprised, given what I face with DC Health and the cluster model for school nurses, that DBH is also proposing a cluster model here. Now, the feedback that I get from some of the nurses on the cluster model, and perhaps its initial rollout was not the best, I'll give that particular caveat, but also from school leaders and otherwise, is that we want to have consistency. We want to know who's going to be in our building each day. And you know, there are changes. I recognize that a school nurse has a completely different function than you all have. Right? Some kid could cut something on the playground. That is not necessarily something that would necessarily pop up in sort of the behavioral health space. But how do you all feel about the sort of cluster model where I think all of you have been at one particular school and you could be transitioned to now you're responsible for two schools? And splitting your time amongst those communities?
So at the end of my first year at Ballou High School, I was informed that I would be, for the back half of last year, splitting my time between Ballou and Kelly Miller Middle School.
Oh, okay. So you have experience with this.
Yes, ma'am. It was, for the first week or so, I think there is any kind of learning grace period. It was definitely a transition. I did find out very, very quickly with my first meeting with the principal and my first meeting with the Connected Schools manager that they were very, very happy and eager to have a qualified clinician in the building. I think that a lot of the learning kind of came from just being in a new workspace. I was learning kids' names. I was learning where teachers' classrooms were, but there was a general atmosphere of, we are just glad to have someone in the building who is going to address these needs of the children. I think that was the focus throughout the interaction and continues to be, even as I'm there today.
That's cool. Now, what would you say is the cap, though? Like,
Sorry.
The cap in terms of number of schools in your cluster, right? So you had two schools that you were sort of toggling between. Is there a number where you would say, no, 4 is too many, 3 is too many, it depends on distance or something to that effect? I mean, what was your caseload like if splitting your time? Did you feel like you were able to fully invest, or that essentially you were split personalities?
I think so. To answer your first question, I think that would depend on the clinician. I think that for me personally, if I were to get to 4 schools, I personally would push back a little bit.
Okay.
To address the second part, I think that yes, I did not particularly find that was challenging to manage my caseload. DBH, the school-based program, caps the caseload at 15 or 20. So when I started at Kelly Miller, I think I had 6 or 7, and then at Blue, I had maybe 8 or 9. So it was manageable, in my experience, anyway.
Okay. Miss Arrington, I think you're the one at the table who has the experience with the high school student. I know you were at Blue, but you've been at Jackson Reed for a longer period of time. The proposal suggests that for high schools, the new model would be telehealth primarily. What are your thoughts on that?
Technically, right now, I am APIT certified. So in my private practice, I do telehealth services. When students are unable to get to school, whether it be school phobia or social anxiety, or if they're not feeling well to come to school for the day, I will see them on Microsoft Teams. So implementing telehealth as a part of the services, I look at it as not a barrier to treatment, but a way for students to receive the services that they need.
But you're hybrid, right? Are you in person at?
I'm in person every
Okay.
day. Yeah.
So that's what I'm saying. Like for some of this, it would be you don't have a clinician, you have a phone number or an email of who you go to. For certain high schools, it would be telehealth primarily. At least that's as I'm reading the plan. It is telehealth primarily, not somebody who's toggling between the two.
I'm okay with it. Speaking from my experience with telehealth, I'm okay with telehealth because we found even during the pandemic when we were virtual and these kids were virtual, we had to figure out how to still provide these services to the students when they're at home for their virtual learning. And so for us, and I can speak from my standpoint, I didn't mind the virtual experience because we found ways to connect with the kids, even if it was playing games or card games. We found websites. We were very innovative in how we were able to reach these students in a virtual space. So speaking from my personal experience, I am very comfortable being in a high school setting, still servicing my kids, because again, I don't see it as a barrier to treatment. I see it as allowing those students to have access to the services they so truly need.
Okay. All right. I went a little bit longer with this panel than I intended, but this was good information. So thank you so much. If we don't have your written testimony for the record, if you could just upload it online. Thank you. All right. We're going to go to our next panel. Leah Kaslas, Kristen Ewing, Chioma Ora, and Dr. Olga Price. Okay, Leah, when you're ready.
Good morning, Chairperson Henderson. My name is Leah Kaslas. I'm a senior policy attorney at Children's Law Center. Thank you for the opportunity to testify today. Many of the children we work with at Children's Law Center need high-quality behavioral health services to achieve stability. Therefore, we, like so many others in the district, see the consequences when children are unable to access timely, high-quality care. We want our clients and all DC children to get their needs met so they are able to thrive. Ensuring we get school-based behavioral health services right is critical to meeting those needs. Given the extensive investment of both time and money in building the school-based behavioral health program, the district should be on more solid footing. But we are not, due in part to DBH's deliberate implementation choices. As a result, the committee considered moving the program out of DBH, but ultimately chose to give the agency another chance to demonstrate a viable path forward. DBH has failed to do that today. We are deeply disappointed by the plan put forth by DBH. We are left with more questions than answers. This committee will hear today from us and other stakeholders, urging them to reject the plan, and mandate an improved process to develop a true comprehensive plan that actually engages stakeholders and provides tangible solutions that are data-informed. My written testimony goes into further detail, but in the remainder of my time, I'll share a few key points. First, the raw data of the environmental scan must be released. During the first round of comprehensive planning in 2018, raw school-level data was shared with the public and informed how the expansion program would move forward. The decision to completely bring school-based behavioral health in-house to DBH should go through the same level of transparency, engagement, and scrutiny. Moreover, the plan itself recognizes that this decision is not fully informed, citing DBH's need to bring in a consultant and collect more data. The report fails to discuss the FY26 higher grant amounts impact, examine DBH's own billing numbers, address the dashboard legislation, or look at key reports including child trends data, the rate study report, or the recent report from the DC auditor on student suicide risk assessment. These and others are all elements that should be considered to support this comprehensive plan. Finally, the decision to bring the program fully in-house does not align with DBH's stated desire to move away from a one-size-fits-all approach. This decision is prescriptive and restricts the flexibility needed for school-based behavioral health programming. Ultimately, the report before us today lacks sufficient data and stakeholder engagement to justify bringing the program fully in-house. We would therefore ask this committee to reject the plan and instead require a stakeholder engagement effort led by a non-governmental entity to develop a true comprehensive school-based behavioral health plan. Thank you for the opportunity to testify. I welcome any questions the committee may have.
Thank you. Kristen?
Good morning, Chairperson Henderson and staff. My name is Kristen Ewing, and I am Policy Counsel at DC Appleseed and co-chair of the Strengthening Families Coalition. The Department of Behavioral Health's comprehensive plan is necessary but not sufficient. The plan lacks transparency, reliable data, staffing details, and authentic stakeholder engagement, making it impossible to evaluate its effectiveness or call it comprehensive. First, there is a lack of transparency regarding the budget and staffing for the proposed in-house model. DBH plans to add 113 FTEs over 3 years, but provides no details on licensure levels, job types, or salary projections. Without this, we can't compare costs and salaries to the current model or assess whether a qualified workforce even exists. Second, the plan presents an unbalanced comparison between DBH and CBO clinicians. It highlights CBO shortcomings without acknowledging a fundamental difference. CBO clinicians must bill extensively for services to make their program sustainable, while DBH clinicians do not have the same level of billing pressure. In addition, the plan includes CBO billing data in the appendix, but omits comparable data for DBH clinicians. Excluding that information and ignoring these structural differences prevents a fair comparison between the two models. Further, CBOs have shared that the increased grant funding for fiscal year 26 is the first time they believe that the combination of billing and grant support could make their model financially stable, yet DBH's plan moves away from the CBO model just as it becomes viable. Third, the environmental scan lacks transparency and rigor. DBH hasn't released the underlying data or methodology despite the scan driving resource allocation. We don't know how often it will be repeated, whether schools can reflect on the sustainability of their current supports in the scan, or if school leaders and families will have a voice in shaping the service model for their school in coming years. Fourth, stakeholder engagement was minimal. DBH held 2 stakeholder feedback sessions with little opportunity for dialogue, and the plan does not reflect feedback from schools, CBOs, families, or youth. It also omits finding from critical sources, including the cost study, child trends evaluation, and the recent DC auditor review of district strategies to address student suicide risk, raising questions about whether this evidence was considered. Finally, the plan overlooks broader system infrastructure and planning, including crisis response, educator wellness, family engagement, workforce development, transition and implementation plans, and cross-agency collaboration. In closing, I respectfully recommend that the committee require DBH to 1, make the raw data from the environmental scan public and specify how and when the scan will be conducted in the future. 2, publish detailed projected multi-year budget and staffing data. 3, outline a comprehensive workforce pipeline strategy. 4, create a transparent, equitable resource allocation model that includes school leader, educator, clinician, student, and family input. 5, evaluate DBH and CBO models using balanced, cost-based metrics, including DBH billing data. And 6, engage stakeholders in a truly collaborative process to produce a revised plan within the year. The district students and families deserve a transparent, equitable, and sustainable behavioral health system. Thank you for your oversight and commitment to the well-being of the district's children. I will be submitting written testimony soon, and I'm happy to answer any questions you may have.
Thank you. Chioma. Oh, turn your mic on. There you go.
All right. Good morning, Chairperson Henderson and team. I am Chio Moru, the Health Justice Project Director at Advocates for Justice in Education. AJE is the federally designated Parent Training and Information Center, the Family to Family Health Information Center for District of Columbia, and we are a Title V implementer for DC children and youth with disabilities and special health care needs and their families. I am also here today as a proud member of the Strengthening Families Coalition, alongside other members of this coalition on this panel and others. Thank you for the opportunity to testify today on DBH's proposed fiscal year 2026 school-based behavioral health comprehensive plan. AJE recognizes the district's commitment, albeit fluctuating at times, to create important community inclusive spaces where ideas can be exchanged through dialogue about strategies to expand school-based behavioral health, such as the Coordinating Council for School-Based Behavioral Health that I have served on since 2018. The proposed fiscal year 26 comprehensive plan identifies trauma-informed care, workforce development, and data accountability as key priorities. These are important steps forward, yet families continue to experience fragmented, inequitable, and exclusionary practices, especially Black and Latina families of children with disabilities who still navigate disconnected systems that too rarely reflect their lived experience. AJE echoes coalition concerns about the implementation and sustainability of the proposed plan. The proposal to deprivatize behavioral health services by fiscal year 2028, bringing all clinicians under DBH employment, may mainstream operations, but risks destabilizing trusted community-based organizations that were enlisted as qualified providers that should theoretically provide culturally responsive care in DC systems of care that DC families of children and youth with special health care needs also depend on these same organizations for services in schools, in the community, and in the home. The plan also reflects a persistent carceral logic that treats behavioral health primarily through crisis and compliance rather than prevention and healing. Despite years of participating as a member of the Coordinating Council since 2018 and the task force the year before that in 2017, OSCE data still shows alarming disparities in behavioral health outcomes, related outcomes, particularly for students with IEPs, those who are economically disadvantaged, LGBTQ+, or in early childhood. Black and Latina students with disabilities remain disproportionately suspended, restrained, or referred to CFSA or DYRS. Additionally, per feedback from families that reach out to AJE for behavioral health supports in schools, we observe that the school-based behavioral health program is viewed more as a system of barriers than it is a system of support. AJE believes that true reform must prioritize. Well, my time is up, but I will say last, if permitted, as both a professional and a mother of two sons who have navigated DC's education and healthcare system since birth, I know firsthand that no plan can succeed without the participation, leadership, and trust of the families it serves. Trust is the currency of an effective school-based behavioral health program. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Dr. Price.
Good morning, Chairperson Henderson and Ms. Huff. My name is Olga Costa-Price. I'm a clinical psychologist, a professor at the George Washington University, where I direct the National Center for Health and Healthcare in Schools. Thank you for this opportunity to testify today in response to the DBH School Behavioral Health Comprehensive Plan. In 1997, I was Associate Director of the National Center for School Mental Health, and from 1999 to 2006, I'm honored to have served in DC government as the founding director of what is now the DBH School Behavioral Health Program. Over the past 20 years, in my role as director of the National Center GW, I have researched and advised on school health and mental health approaches across the country. Furthermore, I co-chaired the task force to revise the preliminary expansion plan in 2017, and my center facilitated the DC community practice for 5 years in partnership with DBH. Based on this research and experience as a leader in the field, I offer the following observations and recommendations for the DBH plan. Despite agreeing with underlying tenets of the plan, there are several fundamental flaws that raise serious concerns. It is problematic for a single agency to act as compliance monitor, regulator, funder, evaluator, and sole implementer of such a complex program. This structure undermines objectivity and erodes public confidence in the conclusions drawn. My greatest concern has been the lack of transparency and the limited opportunities for genuine collaboration. Effective school behavioral health systems depend on elevating the perspectives and assets of all partners so that shared solutions can emerge. Although DBH has collected community input for years, its analysis and interpretation of that information has been opaque, and stakeholders have had little meaningful influence on decisions. Even strong supporters of DBH, myself included, cannot endorse the current plan or its assumptions about the future of school mental health in DC as outlined. The plan should be revised. The data needs to be re-examined with true public involvement, and DBH's predetermined role as sole implementer paused until a stronger justification is provided. We need to understand why performance metrics have gone unmet. Pointing to organizational shortfalls without examining systemic barriers creates frustration and places blame on only one part of a complex ecosystem. The DBH's school behavioral health program's strength has always been its embedded supports. Opportunities for peer learning, consultation, high-quality supervision, and strong school relationships. These are resources that newer and smaller CBOs have not had consistent access to. Without addressing this gap, we will continue to see workforce and implementation challenges. Therefore, I offer several core recommendations. Invest in strengthening CBO infrastructure. This includes providing targeted technical assistance to improve Medicaid billing, as well as expand coaching from DBH School Mental Health to improve provider recruitment and retention, increase use of evidence-based practices, and enhance supervision. I concur that reducing the number of CBOs is prudent, as it would allow for more concentrated delivery of TA for organizations with the foundational infrastructure and demonstrated readiness to serve multiple schools. Ensure genuine community voice. Students, families, and teachers must help shape programs and inform strategic decisions, not simply receive updates after decisions are made. This includes recommendations for revising the leadership structure of the coordinating council and to ensure meaningful engagement of the community. Finally, sustain structured collaboration between government and non-government partners, especially given the large number of organizations providing Tier 1 and Tier 2 supports across all schools. In response to this lack of coordinated system building to date, we launched the DC Consortium for Mental Wellness and Behavioral Health in Schools with over 20 organizational partners. DC COMS is grounded in the belief that people deserve a real voice in shaping solutions and that community participation leads to stronger, more sustainable change. Our work is focused on elevating community voice, connecting research, practice, and policy, and forming productive relationships with decision makers such as yourself to support a coherent system. I have dedicated my entire career to strengthening school behavioral health services in DC and across the country. I urge DBH to adopt a more collaborative and inclusive approach so the school behavioral health program can expand effectively, become financially sustainable, and respond to the diverse needs of students, families, and school communities. Thank you so much for the opportunity to testify. I'm happy to answer questions and will submit additional written testimony for the record. Thank you.
Thank you. Thank you to the testimony for this panel of witnesses. So a couple of you had the similar recommendations around releasing some of the data around the environmental scan. I have some questions about the environmental scan in terms of how does the long-awaited, long talked about, but we haven't ever seen rate study kind of fit into this. But overall, what were the questions that were asked in the environmental scan? Who was asked? Was it the school leader? Was it AP? And how they sort of were engaged in that. So I could certainly follow up with that kind of information. But I'll be honest, I am the suggestion that they take another year on a plan. Yeah, no. We don't have that kind of time. And I think that we've lost a lot of time already to sort of to do that. So we're gonna have to try to figure out, make it work what we got. Although I hear you all in sort of saying that you did not feel like this was a very collaborative process. I'm curious, Leah and Kristen, and even Chioma, because you guys, your organizations are usually involved in some of these conversations with the coordinating council and otherwise. How were you all engaged in the creation of this product?
I'll speak transparently. We were invited to the 2 stakeholder sessions that they held at the end of August and early September, and that was it. We were not invited to engage on the plan any further than that. I will also note that Children's Law Center held a workshop a year ago. You were present, DBH was present, many of the other key stakeholders, CBOs, school leaders were present, and none of the feedback from that session was included in the report. And that was probably the last time that DBH had engaged us in that. We had offered to support with the environmental scan. We were not engaged in that. So yeah, it's been I would say, very limited engagement.
Kristen?
Exact same. I fully
Okay.
support Leah's answer.
Giamma?
Yeah, I support what Leah said, and I would add that as someone who's been on the coordinating council since before the pandemic and served as the committee chair for family and youth during the pandemic and throughout the pandemic. I mean, Olga, we met constantly. We engaged consistently. I saw democracy work in a way that was helpful, fruitful, and moved this process, albeit there were many other constraints that are more economical than it was about the process itself during the pandemic. The process that we have experienced with this comprehensive plan, however, is categorically different. It is anti-democratic. We were invited online. Our cameras were turned off in the first iteration, put on mute at least the second time that we went over it this past week.
Wait, your cameras were turned off?
Yeah, we were unmiked, unmuted. We could only comment on the chat. It was just not the experience that I've had serving with DBH, and I don't know what informs the motions in these anti-democratic ways. And I just urge us to reverse direction and get back to where we were before and even dig deeper. We did a lot of diving, a lot of community work. We were engaged constantly, and that energy has gone. So why? I want to know why.
Dr. Price, in your testimony, first off, thanks for joining us and for remaining engaged in this work for so long and doing that. You talked about your concern around DBH being sort of the sole implementer, like being the funder, doing the oversight, doing the compliance and delivery of the services. But before the expansion, that was the model, right? If I'm understanding the history correctly, before the expansion, DBH was sort of running the program. Why do you feel like that no longer serves where we are right now?
Thank you for your very thoughtful questions and and your commitment to this also. I appreciate that. We began the school mental health program in 1999 with a federal Safe Schools Healthy Students grant. And so by design, it was intended to be run by what was then the iteration of the Department of Behavioral Health. We were not called that. And with the first 16 charter schools. During my tenure there, we grew to 32 schools, but there were also a few other organizations that had soon after really begun to do school mental health. I don't know the year, but for example, Mary Center was providing school behavioral health services as well as others. In 2008, I wrote a report once I left and went to GW that was a landscape analysis of DC and school behavioral health. And I very explicitly said there that the sustainability of this program, in my opinion, was really going to be dependent on whether we could transfer some of that knowledge effectively to our community mental health agencies. That was in 2008. Because I was concerned about the vulnerability and the fragility of being solely in one institution. That is not often how these systems are built.
Was that a concern around funding and continuity or something else?
It was mostly around funding. It was around, yes, continuity. It was around cultural competency. There are community-based organizations that could and do and should be elevated to be able to do this work in communities that they're very familiar with.
Yeah.
And again, I'm very proud of the school behavioral health program. I'm incredibly proud of the quality of the work and the tenure of the clinicians and the supervisory structure. What I feel has not happened is the transfer of what makes them special and what has allowed us to build that to community providers. And once the expansion, after the task force, we sort of tore apart that initial plan from DBH, and the mayor then created a task force and said, please provide recommendations for this comprehensive plan for the expansion. That was in around 2017. And even then, we began to then create at least some outline for how we can begin to do that transfer of work. So between 2008 and 2017, there really was no concerted effort to try to transfer some of that so that we could build the capacity of community providers. And there were, as I said, a few community providers that were doing it sort of on their own, knowing and having good clinical services. But this is really an approach that relies on not just strong clinical treatment, but on other prongs that make this a sustainable model that doesn't rely on waiting until individuals suffer so much that they then have to be in crisis or in treatment services. So it means that we have to work together and be more collaborative, and that just has not happened until more recently. Anyway, so I'll stop there.
Yeah, no, I mean, I hear you on that. I do see us now in a variety of different spaces on the health side of things, transitioning from the reliance on a community partner. Now, some of those relationships perhaps went on way longer than they needed to. Some of those relationships were certainly monopolized in some of these spaces. And so we have ended up bringing in a lot of different services in-house, right? Animal control. Now school nurses is transitioning to in-house. And so I guess I am not bristled at the suggestion from DBH that this now come in-house, because we have seen it happen and move in so many different ways. That being said, there are definitely some gaps in some of that where DBH, although noted, it's going to be difficult, right? You have to ensure that you have Spanish language speaking providers. It has to be part of this, the conversation and the story. How you do recruitment for that is a very specific thing that perhaps some community-based organizations would be able to go to. But what do you say to the point around, I know you said like technical assistance for CBOs and perhaps reducing the overall number so that there's more or less a concentrated number, but it essentially would be the government increasing the grant amount such that you could financially support these organizations' existence in some ways, because they will never bill enough on Medicaid to make it work.
I completely understand what your position and the challenges here. I do believe that it is difficult to draw some of the conclusions that they've drawn because we haven't really sort of engaged in the kind of effort to really test that hypothesis out. For example, this is a systemic issue. Billing for Medicaid for school behavioral health is not a revenue generating approach. This is true across the country, but we can do better at that. And this is both the school behavioral health program and community providers, I think, need to be working much more with our healthcare finance and other advocates to really try to understand where we can push and be more innovative around trying to maximize our billing. And we really don't do very well with commercial providers. So we leave those individuals and those families that have commercial insurance in a tougher position to try to. So I feel like our position is we need to tackle the root causes of what makes the system not work well. And I want to go on the record as saying that I do believe myself, in my opinion, that DBH should still oversee the school behavioral health program. There are reasons, and I'm happy to expand on those. But I do believe that a much more collaborative approach would have and could help us address in a more innovative way what is making us all limited in our success. I don't believe that DBH taking this entirely in-house, that they are going to address those systemic barriers. That is not going to magically make those happen. And so I think we need to be very smart at leaning into the expertise that we have across the city to really figure out why is engagement, why are young people not utilizing some of the services when they have lots of providers there? Why don't we ask the young people? They say, because we don't trust that the clinicians won't talk about our business to other people. That there are approaches we can use systemically across, whether it's DBH or school mental health providers, to say, okay, let's talk about the difference between confidentiality and, making sure that you are safe and privacy. Let's figure this out so that you can take advantage. Because that's another thing. There are providers who are underutilized. That is a shame. We've invested a lot over the years. I've seen it grow. And yet we are still not utilizing services to the capacity we need to. And I think that is a systemic issue. It's not an issue of pointing fingers to particular providers solely. I do think some providers were not ready. There were too many of them, but I think we can do better.
Okay, Gianna.
Yeah, I just want to add that whether or not the CBOs, AJE is agnostic on the question of whether CBOs stay, but we do stand in solidarity with the coalition for this particular reason, or one of many reasons, but this one, which is that no matter if you take out the CBOs from the schools, and yes, you are doing that to sustain, they have their business problems and should probably resolve that, but no matter what, Medicaid dollars are running through those schools anyways. We have a huge problem regardless. I don't see how this move is going to resolve simplifying the complexity of Medicaid dollars that already run through. Majority of the IDEA, as we know, has never been fully funded. So that means related services in schools typically are paid for through Medicaid currently already. And the DBH providers, when they're servicing at the tier 3 level, that's also Medicaid. You still have your Medicaid problem, and that problem is going to be there. And I hope that we do engage it and talk about it. My personal fundamental belief is that this program needs unrestricted dollars to function, and we cannot rely on federal dollars for multiple reasons. As to why we need to do what we need to do to save and protect our families and our children. Let us not ever lose that North Star. And I didn't get to read our recommendations, if I can just briefly streamline them, because I think they may address some of our core position on this, right? AJ, we maintain that a hybrid model that honors community partnerships, not just the CBOs that are in the schools, because there's a bigger question about, are clinicians the only workforce that needs to be invested in here? You have peer workers. Not everybody's gonna go get an MSW. You have your adult public charter schools, and people are navigating those environments, getting their PCA licenses. You have DHCF investing in doulas. Can you put some of those postpartum doulas to work in the early childhood settings? You also have family navigators in some of these same organizations that you want to take the dollars away from, who would, I think, be a complementary workforce. And so we also recommend to create a statutory advisory body within DBH with equal representation for families, youth, and peer professionals. This process should become more democratic, not less, right? With these assigned seats. And I've been asking for structure for many years to the coordinating council, but not like this. And strengthening collaboration with family-run organizations and peer support organizations to ensure culturally affirming, trauma-responsive care at every level. And it's not just about Spanish language speaking, even though we know that. It's Amharic, it's deaf families, it's families who are nonverbal, it's families who are neurodivergent, it's families who are just Black and need culturally responsive people to understand how their Blackness comes into play. It's all kinds of cultural input here. And we know that we recommend that they publish annual public reports on staffing, service delivery, and outcomes, which we never know where that's going, and invest in the parent-focused and youth-focused peer support workforce, which has always been the elephant in the room in this process. This process will only work, not with insurance, but with a workforce, right? Pipelines, and not just social worker pipelines. So those are our recommendations. We are in sympathy and solidarity with the impact on our providers. And bottom line is, we just don't, it's not going to solve what you think is going to solve. So there's that.
Okay. All right. Well, thank you guys so much for your feedback on some of this. Has been super helpful. I will say that the plan that I read doesn't just rely on clinicians. They are introducing a new stream of workforce into it. But Chioma, what you're talking about is in some ways, burn it down and start all over, which, could be good too, in sort of meeting some of the needs of what you're talking about, of bringing in different types of workforce who can meet the needs. And I think that could be an interesting thing because I think they have a thing called, what is it? A prevention specialist position, which you don't need a social work license for that. You need to be able to talk to children and present information, be professional, be empathetic, do all those things, have conversations with families to be able to get a message across around, prevention techniques such that you're not reaching a crisis, which could be an interesting opportunity for us to do that. And to your point around the Medicaid funding, well, I hear you, Dr. Price, and like, oh, we need to be more innovative and what we stretch for Medicaid, but the way CMS is not CMSing right now, I don't know what holds there, but I think it does push us to think about our local dollars and how we're being much more innovative on that. But thank you all so much for being here. Dr. Price, if you could share with us your 2008 report, that would be great. Oh, you have it. Okay, great. All right, thank you so much. Okay, it has been an hour and I've talked to 8 people, so I need to get better. Okay, Nicole Travers, Gracie Obachowicz, I apologize if I'm saying that incorrectly, and you can correct me when you get here. Kathy Riley, oh, hi. So good, I haven't seen you in a while. And Mark Lavoda. Okay, Nicole, when you're ready.
Thank you. Good morning, Chairperson Henderson and members of the committee. My name is Nicole Travers, and I'm a Senior Director of Strategic Partnerships at the DC Charter School Alliance, the local nonprofit that advocates on behalf of public charter schools to ensure that every student can choose high-quality public schools that prepare them for lifelong success. I proudly serve as a member of the School Behavioral Health Coordinating Council. Thank you for inviting us to discuss mental health services in our schools. I want to acknowledge Dr. Bazron, Dr. Scott, and Dr. Sullivan for their work to ensure more schools have access to clinicians and for including charter schools in the School Mental Health Era Working Group. I and other Alliance staff have appeared before this committee repeatedly over the last 5 years to discuss ongoing challenges, including high vacancy rates in school-based mental health programs. DBH data from October shows that 47% of charter schools have no clinicians supporting their students. I'm here today to address the unacceptable number of vacancies of mental health clinicians in charter schools and share our concerns with the methodology used by DBH's environmental scan that informed the plan. To be clear, we take no position on the recommendations of the comprehensive plan to bring clinical services in-house at DBH. However, we see glaring issues with the environmental scan. Rather than using a database survey, the DBH environmental scan relied on interviews with school behavioral health coordinators. This process required school coordinators to provide information they weren't likely to know without pulling data, such as student support services, staff tenure, licensure levels, and caseload capacity. Schools didn't have the opportunity to verify if their input was correctly recorded by DBH interviewers, and coordinators were also unaware if their responses were going to be used to formulate the recommended support levels under the proposed plan. These interviews were conducted in the spring, and that year's enrollment and staffing levels rather than the current year, despite our highly transient student populations. The timing also coincided with high priority end of year assessments, causing many schools not to participate. Additionally, DBH proposes to categorize schools and levels of support based on existing staffing levels and school partnerships recorded during these interviews. We are deeply concerned by this since it does not seem to take into account when an LEA has invested UPSFF or other funds for mental health services. Under this proposal, it appears that schools that invested in securing additional mental health support when none were provided by DBH would now be penalized and deprioritized for support. For example, a school that hired an additional social worker instead of a reading specialist while awaiting a CBO clinician could still be labeled well supported and therefore would then be ineligible for DBH clinical support. While we understand the district's fiscal challenges, we have a few recommendations. First, conduct an additional data collection effort this school year to ensure any changes to the program are informed by current and accurate information about student mental health needs across all schools. Second, host feedback sessions to help define the 4 model criteria and rubric for assigning service models. Schools should have input on their preferred model and provide data supporting the level of clinical needs. Third, inform schools of service model changes at least one school year in advance so that they can plan and staff accordingly. Lastly, allow school leaders to participate in interviewing and selecting clinicians to ensure alignment with their school culture. Overall, the DC Alliance remains committed to partnering with our schools and the district to ensure all students have timely and equitable access to mental health support. Thank you for your time, and I welcome your questions.
Thank you. Gracie?
Good morning, Chairperson Henderson and members of the council. My name is Gracie Obohovich. I am the Director of Educator Wellness for Empower Ed, an organization dedicated to the well-being of DC's educators and advancing teacher-led solutions to the issues we face in our schools. For the past decade, my work has focused on supporting teacher well-being to retain them in DC schools. I am here to express my deep concern about the recently released DBH Comprehensive School Behavioral Health Plan. While others have detailed its structural flaws and lack of data transparency, I will focus on how it ignores a critical component, the well-being of adults in the building. Ignoring adult well-being and teacher voice isn't just an oversight. It demonstrates a lack of systemic thinking from DBH and directly undermines the goal of building stable learning environments for our students. Alarmingly, this plan not only fails to address this, but I believe it actively perpetuates the crisis. It makes three critical errors. First, it was developed without meaningful educator and school leader input. Teachers and teacher leaders are the first responders. They are the ones who will be tasked with implementing any new initiative, adding to their already overwhelming workload. By failing to understand their reality, this plan creates more work for schools instead of solving their problems. Second, and central to my role, the plan completely fails to account for adult wellness in schools. We all know you cannot create a healthy school environment in a building filled with distressed adults. Data overwhelmingly shows how adult belonging and student belonging are correlated. Thus, educator mental health is not a separate issue. It is the foundational prerequisite for any successful student strategy. Finally, the lack of transparency and exclusion of local community-based organizations is a destructive missed opportunity for our system. With mayoral control of both our school system and DBH, I worry that by giving DBH more power, we are furthering a top-down hierarchical approach that avoids difficult truths and stifles innovation. Empowering well-trained independent clinicians and the community organizations that provide Tier 1 and Tier 2 programs ensures a true diversity of quality, responsive services for our schools. On behalf of DC educators, I urge you to not move forward with this plan as is. Send it back, demand that DBH release all taxpayer-funded data for public scrutiny, convene a transparent working group of teachers, leaders, and CBOs led by a non-governmental entity, mandate that any revised plan strategically considers adult wellness supports and continues to include CBOs who have already proven their effectiveness. Let's build a plan with truly innovative ways of providing effective tiers of service. Our educators are not just implementers, they're partners who deserve to be seen as whole human beings. Our CBOs are not a hindrance, they are the partners who will help us build a strong and resilient system. It's time to break down the silos and work together to make DC a leader in school-based behavioral health. Thank you.
Thank you. Kathy?
Thank you. Thank you, Councilmember Henderson. I appreciate this opportunity to testify on the DBH report and plan. I'm Kathy Riley. I convene SHAPE, the Ward for Ed Alliance, and C4DC each month. The need for mental health support in schools has grown since the adoption of the South Capitol Street Memorial Act and the requirement for behavioral health services to be available in every public and private school 8 years ago. I hear the indicators of this need at the monthly meetings. There are traumatized children and families with the increase in detainments and deportations occurring right now. There are continuing altercations necessitating changes in high school athletic event timing and continued concern with safe passage. The increase in the presence of law enforcement everywhere has necessitated the need for de-escalation skills for students and staff and the community. There is need. The problems identified with the current model that I have heard at the meetings include high turnover, difficulty with staffing, poor coordination at some schools with school staff, increase in paperwork required of clinical staff, and some concern with extensive records and student privacy. Further, the Young Women's Project work, supplemented by student feedback, spoke of the difficulty students experience in even knowing how to access help. This is significant. The proposed plan expands the staffing and role of I won't go into that. DBH will use the cluster model that has been used with the school nurses. This has been viewed as a loss by schools that no longer have the same nurse that knows the children and families and that is dependably there every day. It has been a reduction in service attributed to a shortage of nurses. I hope the main questions that will be addressed in the hearing include how, they propose that interns and recruitment of new social workers right out of graduate school, will that be adequately supplemented by more experienced staff? How will DBH deal with difficulty in billing and having an adequate budget with the reduction of federal and local funds on the horizon? While there is a proposed partnership and coordination between school nurses and DBH staff, the coordination with school-based staff has not always been strong, or with families. This is especially an issue with part-time DBH clinicians and the cluster model, complemented by the school nurse cluster model. They are models for part-time support. There is a need for increased input from school mental health staff on this and families. Relationships and stability are the main reasons students and families trust. What steps will be taken to ensure there's little disruption to where personnel have been stable and the healthcare team is working well? And finally, the fear of government-based systems and privacy right now cited by LAYC that I read, they're real. How secure are the systems? Electronic health records advance healthcare and also can compromise it. And I'm concerned with how telehealth will be used. High school students can be as young as 14. Thank you. And there you go.
Thank you. Mark.
Chairperson Henderson, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality, whole-person care for district residents with mental illness, substance use disorder, or both, including the 35,000 district residents our 35-member organizations serve annually. The Department of Behavioral Health's comprehensive plan for school-based behavioral health program should be rejected without qualification. In the face of the council offering DBH an ultimatum to take community input more seriously or risk having the program taken from its authority entirely, DBH proposes instead to bring the program in-house. The plan persistently makes methodological errors, creating the impression that DBH and CBO clinicians work on equal footing, despite different staff qualifications, different financial resources, and different durations of school partnerships. These false comparisons undermine the plan's core analysis and proposed alternative approach. The council will need to decide if it must again ask for a new plan or if even more directive action needs to be taken. My testimony will draw focus to the financial efficiency, clinical value, and scalability offered through the district continuing to offer the school behavioral health services through grants to community-based organizations. For finances, Public Consulting Group found that the annual cost per clinician per school for CBOs was $116,000. DBH reports a cost of $137,000 per clinician. CBO delivered services are $21,000 less expensive. On the revenue side, CBO clinician average billing is approximately $20,000 per school, with about $10,500 actually collected. DBH clinician average billing is $13,000 per school, with about $7,500 collected. CBO low billing is not the performance failure that the plan prevents, but over-reliance on billing revenues has undermined financial sustainability. CBO financial efficiency should be expected to persist for other models, but the plan provides no estimated costs. CBO clinical performance also deserves a more fair evaluation. While CBO clinicians appear to perform adequately or better on performance measures entirely in their control, the plan raises concerns about caseloads and prevention activities, issues that need effective cooperation, both from clinicians and from school leaders and staff members. Building these relationships takes time, of which DBH has a huge advantage over chronically underfunded CBOs. DBH is sending highly experienced independent staff members into well-established school partnerships, and CBOs are doing intensive workforce development for new graduates while attempting to establish trust with schools, new to having behavioral health provider supports, dismayed about the frequency of turnover. Despite this unequal footing, CBO clinicians still make services available that otherwise would not be. Reports from Child Trend show that schools, families, and students have been pleased with CBO clinician experiences, and entire categories of valuable work continue to go unreported and unacknowledged. CBOs also deserve more credit for the scalability that CBO Deliver services have offered. DBH's program did not grow in a strict linear fashion, but instead reached a funding peak of around 50 staff members years before the call for the CBO expansion grants. CBOs have placed 101 clinicians in half the time that DBH placed half as many clinicians. A more thorough review of the plan will reveal other areas that should give the council further reason to reject it. I named several in my written testimony. I recognize I'm out of time. Thank you for the opportunity to testify today. I look forward to answering any questions you might have.
Thank you. Thank you to this panel of witnesses. I think I should say, there have been a couple of witnesses who've said like the council should reject this plan. So there isn't a official mechanism to reject the plan, if that kind of makes sense. The legislation required that they do a plan. They were late, but they provided it. And a lot of this, especially in terms of the implementation of what they've put forward, would come to fruition in the budget. If they don't get the money, the plan does not work. And that's not even get the money from the council. It is if the mayor is not providing them with 50-something new FTEs, there's no way for them to be able to implement what they have put on paper. But I think there is space for us to interrogate what is the plan in terms of the transition process, if there should be a transition process and what should look differently. Ms. Travers, in your testimony, you talked about needing feedback on the rubric for determining which school would do which model. Can you say more about that?
Yes. So in the plan, it names that one size model doesn't fit all, which we agree with, but a school leader should have a voice in which size matches their school. And so in that, school leaders should be able to provide feedback on the rubric to determine and share their own data to identify, okay, I would qualify for this service model for these reasons. And here's the evidence and data that supports that based on my school community's needs in this time. And I think it's important to note that timeline matters when thinking about these models, because you get new bodies of students every year with new circumstances, especially given the environmental changes that happen as well.
Right. And I think that's one of the hard parts, is because the environment of a school can change from school year to school year. And so if they are conducting the environmental scan, let's say we're going to make staffing decisions for school year 26, 27, but then you're going to use data from school year 25 to be able to do that. I understand why you have to, but the entire population of children might shift. And if there's not an opportunity, I hear you, if there's not an opportunity to make adjustments or for a principal or school leader to provide feedback, that can be very difficult. We adjusted that in the school nurse model where, yes, there's data that DC Health is receiving from schools, receiving from families about what students have, what particular health needs, et cetera. But at the start of the school year, a principal has the opportunity to present additional data to say, nope, 5 more children have arrived in my school who have X condition, and then make adjustments based on that. So I think that is certainly important and is part of it. Ms. Opachat?
Obohovich.
Obochowicz?
Obohovich. The C is silent.
Oh,
Yeah.
the C is silent. Okay. I didn't tell you phonics.
Yeah.
The English language is so interesting. Okay. In your testimony, it was kind of interesting because you said like the program or the plan ignores the well-being of adults in the building, but it seems like you're envisioning something completely different than what the school-based behavioral health program is, than what it is today, which is primarily focused on the well-being of students, not on the well-being of adults.
Yeah, I think that we're talking about root causes and kind of the number of adults in a school building and the number of clinicians in a school building and the kind of relationships that educators have and the time that they spend with their students and what those relationships mean and the social and emotional learning that happens there. And to me, investing and figuring out ways to make sure that adults are regulated, adults have the supports that they need, in teaching them how to do more of the social and emotional work, feels like you are going to be really mitigating the tier 3 interventions that have to happen if you can do that kind of systems thinking too. So I think, again, it is thinking about it in a different way, but I also feel like right now where we are with mental health in our schools and students is that we can't put that responsibility just on a couple of clinicians. Like I think it's training and an idea that mental health is something that everybody, like all school staff, share for this to be effective.
Okay. Ms. Riley, you've been convening this group of parents, principals, and educators in sort of the high school space together. Was SHAPE invited to participate in any of the stakeholder conversations with regard to this plan?
No. No.
Okay. All right. Mr. Lavota, you had a super, we'll obviously take a look at your full testimony because I know you were speaking very fast, trying to get through things. It sounds though as one of the things you're kind of promoting is that if CBOs were just better financially supported, this wouldn't be a problem.
Well,
Is that, that is a very juvenile explanation, I think, of what you're trying to say, but am I sort of on the right track?
I think that that's on the right track if we're only talking about the current school behavioral health expansion. I think what I want to draw attention to is the failed contrast with CBO clinicians versus DBH clinicians, because DBH clinicians really do have a different staffing model. They have a different financing model, and they have a different school partnership relationship. And we keep trying to pit these against each other. Let me be clear, and I say it in my written testimony, I give you a full paragraph in my written testimony. I don't think the DBH clinicians do a bad job. I think a lot of them do really excellent work. I think this plan and DBH's approach generally is just not giving CBOs credit for the contributions that they're making, both at the individual clinician level and at the level of how CBOs collectively are contributing to the system. In part, and it is a meaningful contrast, CBOs are hiring new master's graduates almost exclusively. DBH has an internship program for 14 students or something like that. We're training 101 new graduates every year, or at least half of them because of how high turnover is. We're training tons of new graduates every year doing this program. And we're doing it without the financial resources we need. And then there are also not the financial resources to retain those staff beyond the time that they get their independent licensure. I'd love to retain those staff, and I think that some of the clinical gaps that we see, they would fade away if we were going to pay the CBOs to do a different model and keep people once they get their independent licensure as long as we can keep them. But that's not what we're doing. We are doing something fundamentally different. And so the comparison is already an unfair comparison. And then we have to deal with just kind of the analysis gap around DBH is already withdrawn from a lot of the schools that the CBOs are now going into and having a hard time with. Like, DBH clinicians succeed in part because the schools that they're in have well-established understandings of what it means to work with clinicians. We're doing a lot of that education work, and we're doing that education for the clinicians at the same time that we're doing that education work with the schools. DBH right now doesn't have those challenges, and I think DBH maybe underestimates how much it would have those challenges bringing those services in-house, working with less skilled staff that CBOs are doing right now, and implementing all of these different models.
Okay. There's so much more I want to delve into there, but if I don't keep going, we'll be here into the evening.
Well, you can follow up with me.
Yeah, but I'll follow up with you. Thank you so much to this panel of witnesses. Thank you for your testimony, for being here today. All right. Victoria Roberts. Okay. Michael Lee. Shanita McComb. Okay. Kashana Watson. James Marfiano. Okay, Ms. Roberts, when you're ready.
Thank you for the opportunity to share Community of Hope's experience with the school-based mental health program. I'm Victoria Roberts, Vice President of Health Services at Community of Hope and a board member of the
You're going to have to speak up just a hair.
Okay, DC Behavioral Health Association. COH is a nonprofit federally qualified health center and homeless services provider. We provide medical, dental, pharmacy, and behavioral health services with a total of 29 FTE behavioral health providers serving over 2,100 people so far this year. COH was also in the first cohort of CBOs recruited for the SBMH program in 2020 and has maintained relationships with 3 schools since that time. We work in 2 high-need elementary schools in Ward 8, Ketchum and Moton, and Roosevelt High School in Ward 4. DBH has chosen to withdraw DBH clinical services from both Ketchum and Moton. We have excellent relationships with all of the schools and routinely have received positive reviews from the principal surveys, most recently with one commenting that our clinician is a great asset to the community, and another that the COH behavioral health program provider has been a game changer for our school community. They are very active, visible, and resourceful beyond our imagination. The latter, Roosevelt High School, has requested that we provide a second clinician, which of course we are not allowed to do under the current agreement. COH is strongly opposed to DBH's proposed plan to bring all services under their umbrella by 2028. I'd like to emphasize that this is not based on our desire to protect our participation in the program, which is small, but is rooted in our sincere belief that this would not result in better outcomes for DC students. We agree with the testimony that Mark Lavoda shared that it does not make financial sense to pursue this plan, and that the DBH report misrepresents both CBO and DBH performance. We take strong exception to the representation of our performance, and we're happy to provide further details as to our outcomes upon request. We know that we are making a positive impact for the students, families, and staff, and that our services are much needed. But this has been a difficult program to participate in, and so we have not expanded our participation in additional schools as we originally intended. Examples of the barriers to success include DBH's one-size-fits-all approach that does not take into account the variety of needs and approaches that the program requires. CBOs, on the other hand, have both flexibility, resourcefulness, and in our case, access to additional resources that provide deep support to students and their families. DBH has refused to update data to include many of the services that we provide, crisis management in particular, mental health consultation, and walk-in supports. These are considered foundational activities, not Tier 1, Tier 2, or Tier 3, but they're a large component of our activities, particularly in the elementary schools, where parent engagement and formal counseling can be difficult and slow. Outdated curricula, we believe, do not meet the needs of the school or the students. And so DBH is upset that we're not following, but we have good reason. And there are restrictions on how clinicians must be in schools during the summer, even when students aren't, even when nobody else is in the building. I will submit written testimony with more specifics on these items, but I will say throughout the years, we've worked hard to be a committed partner and to offer suggestions to improve the program. We think that a new approach from DBH would truly take into account CBO, school, and family feedback, along with appropriate financial support, would allow the CBOs to achieve the goals of the program. And I'll be happy to answer questions.
Thank you. Ms. McComb.
Good morning. Thank you for the opportunity to testify today. My name is Shanita McComb, and for the last 5 years, I've had the honor of working as a clinical supervisor and therapist for the school-based mental health program with Catholic Charities DC. Since 2019, the program has supported students in their communities with mental health services through individual, group, and family sessions to children in over 20 schools in DC. Prior to becoming a clinical supervisor, I started as a school-based mental health therapist assigned to an elementary school in Ward 2 serving children and families. Over the course of 2 years, I provided support to 20 children through individual therapy sessions on a weekly basis and helped them process adverse childhood and traumatic experiences, building coping skills, increasing emotional regulation, developing pro-social skills, building self-esteem, and developing conflict resolution skills, and so much more. During my time in the school community, I also provided over 800 individual and group sessions. When considering why these mental health services are important and needed in the school community, it's critical to note that every child who was referred to me presented with severe adverse childhood experiences, traumatic experiences, high levels of anxiety, depression, PTSD, grief, and loss, to just list a few. These children struggle significantly with coping, which impacted their daily functioning, from declining academically due to stresses resulting in severe behavioral challenges such as elopement, school avoidance, not following school rules, directive, engaging in fights, bullying, destroying school property, and engaging in community violence. These students just needed someone to see their pain and help outside of the academic classroom. Most of these children lack support to help them heal and cope, and have only someone like me, like my colleagues, all professionally trained therapists to support, heal, and help them get stronger to cope with the challenges they face every day. But we need more of us, not less. Now, as a clinical supervisor, I guide clinicians through this life-saving and important work. As a DC native, I can see and know we have made significant progress with decreasing the stigma of mental health by enhancing awareness and providing resources to support wellness, stability, healing, and human development. Removing this support from schools will only hurt these children and severely set them back, breaking their path towards stability. As I reflect on my experiences, I was able to help one student and her family with obtaining financial donations to assist the family of 10 with their basic family needs. What's more, with consistent engagement in therapy, this struggling student was able to graduate with honors. Students like this need our continued support, and community-based organizations can offer additional levels of support and resources in the school setting. So I urge the council to maintain school-based mental health services through CBO so that we can continue building a stronger and healthier generation of people in our city and in our community. Thank you for your time.
Thank you. Ms. Watson? Hold on, you do need to turn your mics off. There we go. All right, there we go.
Thank you. Good morning, Councilman Henderson. Thank you for the opportunity to appear before you today. My name is Kashana Watson, and I serve as the Clinical Director of the School-Based Mental Health Services Program at Catholic Charities. Since 2019, our program has partnered with the Department of Behavioral Health through the Expansion Program to provide essential mental health services to students and families throughout the District of Columbia. We are grateful for the partnership, and we're here today to testify for ongoing support. Since its inception, our school-based program has formed partnerships with more than 20 schools across the city, serving over 2,000 students and providing more than 60,000 critical mental health services within school communities. When I joined the program in 2019, our collaborations included only 3 schools. Over the past 6 years, I've observed significant expansion in both the reach of our services and the strength of our relationships with school leaders, educators, families, and students. As a native Washingtonian, I am personally and professionally invested in this work. I continue to reside in this vibrant city and maintain a deep connection to the students and families we serve. My testimony today is rooted in this lived experience as a parent and in our shared commitment to promoting healing, stability, and access to high-quality mental health care for the children and the youth of the District of Columbia as a clinically licensed clinician. At the outset of our program, many school leaders understandably expressed concerns regarding the sustainability of the program, specifically the duration of our presence, our level of commitment to their communities, our alignment with each of their school visions. We address these concerns not only with our words, but through our consistent presence and steadfast partnership, as evidenced by our high satisfaction from school leaders through our quarterly surveys. Many of our therapists have served in their schools since 2019, consistently supporting students and families that have been affected by trauma, attachment difficulties, and significant loss. The continuity that we have with the school communities has established a level of trust, a critical foundation developed through sustained reliability and dedication. In addition to their commitment, our therapists have distributed clinical expertise and resilience, receiving training in trauma-informed CBT, EMDR, narrative therapy, play therapy, therapeutic yoga, and other evidence-based practices. Currently, our program is matched with 14 schools where we provide individual therapy to more than 300 students in the district. Additionally, we've delivered hundreds of Tier 1 and Tier 2 interventions just this far, reaching entire classrooms, school communities with prevention, education, and group-based support. This has been our impact just since the school year has begun, and we aim to maintain this service level under the partnership moving forward if allowed. The impact of these services cannot be overstated. For many of our students, our clinicians represent a consistent and trusted source of safety and connection, often serving as the first step towards long-term healing. Today, my colleagues are here with myself in our unwavering commitment to the children and the families that we serve. We respectfully request the continuation and sustained funding of this project and our partnership with DBH to ensure the students continue to access high-quality mental health care without interruption. I do see that I'm out of time here, but I want to thank you for your time, your leadership, your commitment to the mental health and success of our city's youth.
Thank you. James.
Good morning, Councilman Henderson. Thank you for the opportunity for me to testify. My name is James Marafino, and I'm a clinical supervisor with the Catholic Charities School-Based Mental Health Program. I started with the team in September 2020 as a therapist during the height of the COVID-19 pandemic. Through my 5+ years, I have served as a therapist in 2 schools and became a supervisor with this program to support 6 therapists placed in schools throughout the district. As a therapist, I worked on the front lines with middle school students who had experienced trauma and readjustment issues when returning to school during the COVID-19 pandemic. I engaged with multiple students who had experienced crises such as suicidal ideation, homicidal ideation, food scarcity, and loneliness, to name a few challenges. During my time in the schools, I had the privilege of working with Robert, a student who had experienced PTSD symptoms due to the loss of his older sibling in a car accident. While he struggled with intense anger at home and in the classroom, Robert made significant improvements in his mental and emotional well-being through therapy sessions in the school. Through patience, compassion, and acceptance, Robert developed strong coping skills and processed many challenging emotions. By the end of the school year, Robert was presented with the Student of the Year award. I have no doubt that the therapy services from this program allowed him to achieve this award. As a clinical supervisor, I have the unique opportunity to support 6 therapists placed in different schools throughout the entire district. Through them, they currently provide direct services to nearly 70 caseload students this school year alone, while simultaneously are engaged with the entire school community through resource sharing, drop-in sessions, social and emotional learning classroom presentations, and small groups focusing on coping skills and processing emotions such as grief and loss. I also have the opportunity to visit my therapists at each of their school placements and see the positive impact directly, as students will constantly walk by and wave at them. Taking away these resources would further traumatize students and their families, as this would break down the comprehensive wraparound care our clinicians have established and strongly developed over the last several years. Mental health disorders in children such as anxiety, depression, and PTSD will go untreated, and they will continue to impact our students negatively in their academic and personal lives. However, if you continue to support us in our efforts, we can collaboratively address these concerns and provide the care, support, and compassion that our children need. Thank you very much for your time.
Thank you. All right. Thank you to this panel of witnesses. I think our first group of all CBOs. Ms. Roberts, I thought your testimony was very interesting and sort of Community of Hope like to expand participation in the program, but it's been very difficult to do so. And you named a list of difficulties in terms of dealing with the expansion. In your experience for the organization, how has been the feedback loop with DBH around some of the rigidity that you have brought up about the program?
We have found it difficult to get our needs, our concerns across. Occasionally, we do. I think one example would be currently, and I think this was mentioned in the previous panel, DBH is asking for a very detailed account of pretty intense levels of data on any of the issues that the students who are participating in our services are having. So if they were to have criminal involvement, we're supposed to report that in this database to DBH. This not only undercuts our sort of license judgment by our providers, it will undermine trust with the students as well. And we all have a lot of concerns. So Community of Hope was not the only one who had concerns about this, but I'm not sure that we're going to be able to break through with an understanding of how problematic that is. I would say the summer requirements would be another example of that, of it does not really make sense. So we do a pretty significant amount of billing. We've done 750 visits so far between our 3 providers, different, most at the high school, partly because the high schools request that we emphasize that there, as well as just the nature of, consent being easier with teenagers versus elementary. I think one of them has 250, but that reflects no activity over the summer. The families are not interested in bringing the kids to the schools that are shut down. We have facilities close by where we could easily have those providers
Come to one of your
come and
facilities.
see us. We could do telehealth visits, but they want us in those schools. And sometimes the technology is not great in those schools for supporting telehealth visits either.
Yeah, but also, I'm thinking of like a large school like Cardozo or like it's empty
Yes, it is.
and lonely.
Yes.
In the summertime.
Yes. And so there's just, billing data. We bill $30 million of income yearly. We're quite experienced at billing. And when billing data has been requested, it's been requested in such a way that it doesn't really understand the nuances that are there. A claim can be in a variety of statuses, for example. It could be waiting to be paid. It could be being, could have been rejected, but we're, challenging that denial. There's a whole variety of statuses. I just think DBH just doesn't understand. But instead of learning from an experienced billing provider, we just haven't been able to get through.
So I think that one of the challenges is that in sort of the expansion period, we've had so much focus on making sure that there is a clinician that is tied to a school and getting up sort of the vacancies that I would say even for us at the council, we haven't necessarily focused on quality. And I'll be honest, I'm not entirely sure what that evaluation of quality in service delivery would look like.
Right.
Beyond did you show up like you were supposed to? Are you having conversations and those kinds of things? But to be frank, the only people who really can evaluate quality in some ways is either the young person who is involved, sort of, right?
Yeah.
I know, quite put an asterisk
I
on
do
that.
think qualitative data is important, but as experienced providers, we also use quantitative data. We apply the same modalities and oversight for our school-based groups as we do for our other clinicians, which include, are we seeing improvements in screeners that we're doing? We also tend to, people have reasons why they're coming in, including even young children. Why is it that you're here? And we need to meet you with what your goals are. So we could say, yes, your screeners are showing you're less depressed, but what you wanted to do was to feel more confident in talking with your parents. So we also evaluate with the students, how are you feeling about that? Are we achieving what it is that was important to you? And so, we're pretty skilled at that, but I think that we're never asked to share that level of expertise that we have.
Okay. The trio from Catholic Charities, I'm curious in terms of how you all would view some of the feedback that Mr. Lavoda provided on the previous panel, in terms of, yes, you all are providing services, but also you are a main source of training. I think two of you are supervisors and one of you is a director. So you want to speak to that a little bit?
So I actually started with Catholic Charities in 2017 as an intern. So this is my part-time role. I'm actually the senior clinical manager for community support services at Catholic Charities.
Got it.
So they have retained me. So it is training ground. We train so many students coming in. I have 3 interns as we speak right now. So to speak to that, I do think CBOs offer that opportunity for you to grow and develop.
Yeah,
at that
I
level.
would be interested in sort of the larger conversation if we were talking about social work and supervision hours and all of these different things. What happens if a CBO does not exist? How does someone accomplish what they need to in order to reach licensure? in that way is an interesting question, not the basis, but it's certainly something we should certainly consider. I don't know if either of you wanted to add something.
Yeah, we have a really robust internship program that we've often been consulted with by DBH in terms of how we've recruited interns to kind of not only just come to work with us in school-based, but to work in our general agency. We have 2 of those here with us that you will hear from shortly that started with us out of Catholic University, out of our partnership with them, kind of our pipeline to social work program that we currently have been running for about 4 years now. And they started with us as interns. And they are now here as licensed independent social workers, right? LGSW, sorry, correction. LGSW social workers. So we have access to students. They come and they learn with us. We train our people up and we definitely promote from within so that we can have continuity so that our school communities don't just see them as therapists, they see them come back as leaders to support them in leadership capacity as well.
Okay. All right. Well, I don't have any further questions for this panel. Thank you so much for your testimony. And if we don't have your written testimony for the record, if you can make sure you upload it. Okay. Grace Birth, Julia DeGrillo, Karen Jones, and Victoria Asola. Okay. Who's Grace? All right. You're up first.
Good morning, and thank you, Chairwoman, and committee members for the opportunity to speak in front of you today. My name is Grace Birth. I'm a licensed graduate social worker with Catholic Charities and a former intern. And I'm a school-based mental health therapist. I'm here to testify today, sharing my concerns about the decision to remove community-based organizations from school-based mental health in the district. I started as a therapist in an elementary school in May this year, and I can already see the vast impact of the program on individual children and the community. My role in the school ranges from conducting individual sessions, family sessions, consulting with teachers on the well-being of students, running therapeutic groups, presenting and engaging with staff on mental health, and so much more. I want to highlight a few examples from my time so far. I have a boy with ADHD and significant frustration, often leading to fighting, emotional outbursts, and thoughts of self-harm. He's able to come to therapy, work through his frustrations, develop coping skills, and reduce unhelpful behaviors. But he was also able to utilize medication management due to the wraparound services at Catholic Charities and Anchor Mental Health. Due to the variety of services provided at community-based organizations like ours, he was able to get medication services with ease and effectiveness. And there are many other programs that we can connect him and his family with as well. Another student I have is a young girl who has experienced significant loss and community violence with a diagnosis of PTSD. She suffers from severe flashbacks, nightmares, and emotional breakdowns at home. But at school, she has good grades. She does not cause a distraction. She's quiet and nervous. She does not qualify for an IEP or a 504 and therefore would not be eligible to receive consistent services from school mental health professionals. However, if she does not work through her PTSD now, I believe the effects can be long-lasting and pervasive. Children like her who are pleasant in class but struggle deep down will fall through the cracks of receiving mental health support when we limit who and what schools have access to mental health therapists and when we limit our presence in the school. Lastly, I want to highlight the burden that our presence in schools can alleviate for members of the school community. In joining my school, I was able to transition multiple students without IEPs and 504s onto my caseload, and doing so allowed the school mental health professionals to more effectively provide services for students with disabilities, as they were no longer supporting my students in the same capacity. School-based therapists are needed everywhere, as our presence allows for streamlined service delivery and targeted intervention for kids both on and off of our caseload. To conclude with this, without the program in the shape that it has now and without strengthening it, without the current scope, the children in our community would be negatively impacted. I ask that we continue forward with community-based organization involvement in the school-based mental health program. Thank you.
Thank you. Julia?
Good morning, and thank you for the opportunity to testify today. My name is Julia DiGirolamo, and I'm a school-based therapist with Catholic Charities DC. I began working with the agency in July 2024 and am now in my second year serving in this role. I've become an integral part of the community at my school, and today I'd like to speak about the critical gap in services that would exist without community-based organizations like ours. During my time with Catholic Charities, I provided almost 500 individual therapy sessions to students. My work helps close the gap for children who do not qualify for an IEP or 504 plan, but still need emotional and behavioral support. Take a student I work with that I will call A. A has witnessed domestic violence at home and struggles with symptoms of trauma, including emotional outbursts. When A was referred to me, I focused on building trust and creating a safe space, consistent space for him. Every Thursday morning, A knows that I will be there to pick him up for our session. On the rare occasion I have to reschedule, A becomes visibly upset because this time together has become an anchor for him, a sign that he is seen, supported, and valued. This relationship extends beyond the therapy room. When A's family faced homelessness last winter, I was able to connect them to resources and wraparound support through Catholic Charities DC housing and shelter services. That holistic care, supporting both the student and the family, is what makes community-based organizations so vital. We are the support and bridge to connect our students and families to the comprehensive care they need and ask for. A is just one of many students who rely on these services. Without school-based clinicians from community-based organizations like us, students like A would fall through the cracks. We help fill the space between school systems and outside agencies and support, ensuring that every student has access to the care that they deserve. So today, I urge the council to maintain and invest in school-based mental health services. Your continued support allows us to build stronger, safer, and more resilient futures for our children and their family. Thank you.
Thank you. Karen?
Good morning. Greetings, Chairperson Henderson and team. My name is Karen Jones, and I am a proud native Washingtonian and 30-year resident of Ward 8. While I have served this and other wards for the past 28 years, for the past 5 years, I've dedicated and committed my skills as a school-based mental health therapist in Ward 8, which, as we know, is one of the most at-risk wards in the District of Columbia. In this role, I have provided direct services to children and families through assessments, referrals, clinical diagnosis and treatment, advocacy, and connections to internal and external community-based service providers. As I am deeply concerned about the future of our children in the schools that would be impacted by this decision, I do appreciate this opportunity to testify before you. Since joining Catholic Charities DC School-Based Mental Health Program in 2020 at the height of COVID-19, my colleagues and I worked innovatively and tirelessly to pivot to the needs to students across the district. We pivoted and provided services virtually, such as online camps, telehealth sessions, parent engagement workshops, newsletters, and even delivered door-to-door food and camp supplies. Now on site, we have increased our commitment tenfold. By collaborating with administrators, families, and staff, we've helped reduce the stigma around mental health, create awareness, provide real-time support and strategies, shared language, and a trauma-informed perspective for the safety and well-being of all students. My 5-year work briefly speaks volumes of what we are collectively achieving in having these services within the school. Having served approximately 80 families over the past 5 years with more than 1,300 individual, 70 family sessions, 400 Tier 1 and Tier 2 services, and have ensured a safe space for about 100 clinical groups. And I've successfully discharged 40 students from my caseload. We are bridge builders, lighthouses, truth seekers and tellers, and genuine partners with our children, families, and schools. I know we are effective when students diagnosed with, I'll say PTSD, due to domestic violence, community violence, can talk and cry about it, examine, and even change their viewpoints and behaviors. I know we are effective when trusting relationships with family members result in parents and caregivers accessing mental health services for themselves. I know we are effective when a displaced student removed from his home with a new caregiver, new school, and a new community after 1 year of engagement is now thriving mentally, emotionally, and academically, so much so that he recently graduated from our program. And I know that we are effective when students who struggle with understanding and managing sadness, anger, and shame around having incarcerated or absentee parents can stay in class a full day. Keep in mind that these are all children under the age of 12. Please reconsider your decision so that we can continue our committed work with children, families, and the school communities. As you can see, the need is great, the relationship is strong, and the trust is unquestionable. Thank you for your time.
Thank you. Victoria?
Good morning, and thank you for listening to my testimony. My name is Victoria Isola, and I have been a school-based therapist at 2 schools with Catholic Charities school-based mental health program over 5 years. Our school-based mental health services are not just helpful, they're essential. Let me explain. Our students come to school carrying stress, anxiety, grief, and sometimes trauma. For many, the support they receive at school is the only mental health care they have access to. What's more, we are likely their only support system. Over the last 5 years, I have provided over 400 universal preventative services to students, teachers, and parents through school-wide programs that build community, teach emotional regulation, and strengthen social connections. These efforts set the foundation for a positive school climate and help prevent larger issues before they begin. For those needing more support, I provided more than 350 targeted evidence-based interventions. These are small groups to help students manage anxiety, navigate friendships, self-regulate, and build coping skills. This is in addition to providing support to staff and teachers at the school. At the most intense level, I have provided approximately 2,000 intensive individualized interventions. These are one-on-one individual sessions, crisis interventions, and coordinated care plans designed to meet the students exactly where they are. I provided 407 drop-in visits, students who came on their own because they needed someone to listen, a safe space to cry, and help processing what's going on in their lives. Each of those moments represent trust, courage, and connection, the heart of what school-based support is all about. Over the course of my 5 years, I also helped my school face unimaginable challenges, including the unexpected passing of a beloved teacher and the trauma of a community shooting that students were close to. These events have shaken our school community deeply, but they have shown us how vital it is to have trained, compassionate professionals embedded in our schools, ready to respond when crises occur, to comfort our students and staff, and to begin the healing process right away. Our data show the reach of these services, but behind every number is a student, a life impacted, a burden lightened, and a young person who feels seen and supported. School-based mental health services are not a luxury. They are a lifeline. They keep our schools safe, our students connected, and our community strong. This is why CBO clinicians need to stay embedded in the schools. Thank you for the opportunity to speak today.
Thank you. Thank you to this panel of witnesses. I don't know if you guys coordinated your colors here. I'm noticing, oh, the Catholic Charities folks, everybody's wearing green. Oh, I see. Okay. Layers to it all. Intentionality and yes. I do have one question sort of for all of you. Have all of you engaged in drop-in visits? We have students who drop in. Okay. It was sort of listening to Victoria in your testimony. You sort of talked about the drop-in visit. And I'm not going to call it a phenomenon, but it's just sort of like what happens. And I think that is a question for if you transition to a cluster model, if you transition to something in that you are essentially taking drop in out because you can only drop in for the hours for which I am there. And it could be the morning, it could be the afternoon, it could be I'm only here during lunch because of the other things. And so I don't lose sight of that, especially hearing in all of your testimonies talking about there are students who don't have IEPs, who don't have 504s, who need this additional support. And frankly, that was one of the purposes of providing this additional support around school-based behavioral health, because you had guidance counselors who are at schools whose caseloads were taken specifically by students with IEPs and 504s, and they couldn't necessarily support the students who didn't have those specific challenges. And so I definitely think that that is something for us to think about, because I feel like all of you brought that up. Did you want to add something, Grace?
Well, to touch on like the cluster model, and it's just this thought's been evolving as I've been sitting here, is that my presence in the school is in part how I'm identifying students to bring onto my caseload. So when I'm there at lunch, when I'm there at arrival, because I'm in the school every day, is when I see these kids come in dysregulated, and they're kids who we don't realize that things are going on at home until I see them because of my involvement in the school, or someone flags that they need a drop-in session, and that could become a kid on my caseload. But if I do not have time to make myself available for drop-in sessions, I feel like there are kids that I'm not able to identify at that point.
Yes.
And I just wanted to add to, like, just touching on the importance of building community within the school. Because you do become a part of the fabric. You are valued in a different way by being there and as a consistent presence. And we do model behavior for teachers. We do, educate teachers on appropriate language, on use of strategies, use of tools, and just a different perspective to look at how a kid is showing up in school. And so becoming a drop-in person does not give you that opportunity to really build relationship, build rapport, build trust, or sustain it, or grow it, or change culture in schools that aren't trauma-informed, that move only from a perspective of education. And I say that because I work in Henley Elementary School in Ward 8, and even getting principals to look at how they operate with their staff differently has been a big part of my success. Noting the differences in how you treat your staff and what the impact of that is on the children who now have to step into these spaces where teachers sometimes don't feel that there's a shared value. And so I don't just facilitate to children. I facilitate to the custodial workers, the cafeteria workers, the teachers, the school nurse. My mental health team, is family. And so I don't think you can get that just dropping in every once in a while.
Can you talk a little bit about, because you kind of mentioned Henley, but I don't know that necessarily the other schools that you guys are a part of, but one of the things that DCPS has sort of grown more towards is having wellness teams.
Yes.
And how you all engage and interact, being a CBO, not being part of the DCPS staff, but how you engage and interact with those folks.
I would say my wellness team at my school is phenomenal. And when I came in, they treated me like I was one of their own. Like, those social workers at my school work 110%, and I'm able to fill those gaps with drop-ins, right? Like, they'll come to my office, and besides the chit-chatting that we do, it'll be like, I don't have time to meet with student X. Can you meet with them? And I'm able to fill that gap. And I think collaborating as a team, which is something that we have constantly worked on as a mental health team at my school, we've come up with, I think, talks. I named them Taco Tuesdays, where we talk to staff, and we, myself included, will provide mental health information, and we'll provide trainings and trainings on self-care, trainings on how to notice behaviors in the classroom, and what kind of referrals are offered.
That's good, because there was a witness earlier, Gracie, who was talking about the need to also address sort of the educator well-being. And I would say even for, there are some schools, my kid's school or whatnot, the consistency piece is super important. My girls come home, I get a readout of who wasn't there that day, every day. Every day, so-and-so wasn't there and such wasn't there. And, I missed her and blah, 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 right? It is, you would think it's small, but it is noticeable. And also sort of the building of community and fabric pieces where, right, like the security guard who is there every day, the security guard is just as important as the educator and just as important, right? Because that is a consistent presence, but also if they're good, and I'm not saying that all of them are great, but if you're good, they know every kid's name and what kid goes with what parent, which I think is such a skill. To be able to say, you, I don't know you. Come over here. I need to see ID and check the paperwork. But, oh, hi, Miss Smith. Good to see you. Are you here to pick up Max? Or are you here to pick up Gracie? Like, they're able to sort of do those pieces. And so I don't know how I think that's something we're going to have to sort of reconcile. We acknowledge that schools need different levels of attention and different levels of support. And I think one of the things that DBH was trying to accomplish in their plan is the acknowledgement that not every school needs the same level of support. There are some schools who need more, depending on what's happening in their communities, et cetera. And if you have a situation where you have finite amount of resources and workforce, how do you accomplish all of those things? So I want to, acknowledge that. But the switching of telehealth is fine. They were talking about telehealth on NPR on my way in, right? The importance of telehealth and how Medicare is not allowing billing for telehealth because Congress can't get their act together. So it is certainly expanded in the way that they do it. And I know that for some young people, they're like emotionally attached to their device. We are trying to break them up from that, right? Which is why we don't allow cell phones in schools during the day anymore. But it's a tool. It's not a solution. It is a tool. Should we base our models using that type of tool? I don't know, but I'm riffing here when I should be moving on. You wanted to speak, Ms.
Yeah, just lastly, in terms of like the mental health team, I think what has been very successful for us at Henley is that, for one, we have 2 seasoned social workers who've been there invested for over a decade. But for 2, and there's a psychologist on our team, but everybody is aware of what their roles are. Everybody stays in their lane. Everybody respects the expertise that each person brings to the table. And we're able to disperse ourselves throughout the school based upon what it is that we do. We collaborate on referrals. We collaborate on wraparound services. We collaborate on special events. And so it is a self-sustaining team because we kind of get the big picture.
Yeah, but I think it's also speaking to what you said, right? I don't know how you do an environmental scan if you don't know who's already in the building. Right? How many school psychologists are already there? How many existing therapists are there? How many social workers are there? But even going a little bit deeper, the fact that there are 2 social workers who are at the school who have been there for over a decade, it might be okay then for a new person who might not have that many years of experience to be able to come into that environment. But you might not want to have 5 people who brand new coming into a certain school because somebody's going to have to lead in that regard. All right. Thank you so much. Thank you for your testimony. Okay. Juliana Lang, Haley Dreyer, Frankie Seabraun, and Carlo Shavara. No, I don't see Frankie. Yeah. Okay. Who's who? Julia? Are you Haley? All right. There's no Carlo. Okay. Dr. Morales Black, I see you. And Carolyn Greenspan. Okay, great. All right, so that's who I have who's here for in person. Now, is there somebody in this space you thought you were in person, but you're... Okay. We will catch her on the next one. If she comes back in. Okie dokie. Juliana, when you're ready.
Good morning, and thank you for listening to our testimonies today. My name is Juliana Lang, and I work with Catholic Charities, their school-based mental health program at KIPP Heights in DC. It's in Anacostia, Southeast DC. I was actually an intern with Catholic Charities first, and then when I graduated, I became their employee. Since starting at KIPP Heights in August of 2025, many of the children who have sought my help or have been referred to my services have been exposed to domestic violence, community violence, been raped, and either been shot at or had family members who have been fired upon. 2 weekends ago, one of our students, a 7-year-old, came face to face with gun violence and was directly shot. He's doing okay. He's recovering. Another one of my students lost a brother to gun violence and now experiences post-traumatic stress disorder, causing him to start fights with other students, throw objects, and hit his teachers when he's dysregulated. He becomes irritable quickly and he struggles to make friends because he has a hard time with anyone who's close to him because he's afraid to lose them. He has told me that when his mom leaves the house for more than 30 minutes, he fears for her life. On a daily basis, I work with young children who struggle with depression, anxiety, explosive disorders, and PTSD. These children can do their work just enough that they're not eligible for an IEP or 504 services. And their teachers are trying to educate an entire classroom and are unable to provide individualized time to process their trauma, emotions, or thoughts that they might be experiencing. That's where someone like me or a clinician from a community-based program steps in on campus. Without us, these students are unable to receive the support they need to heal and thrive. My role allows me to focus 100% on these students for their individualized one-on-one support. They need that attention and they need that time. Without our support, these children would otherwise fall through the cracks. We will see a rise in children committing suicides and homicides as poverty, food insecurity, and incarceration would once again grow. As a school-based mental health clinicians from CBOs, we build bridges together by providing individual and family services along with social and grief groups for a healthier, more stable community. We provide comprehensive wraparound care, and honestly, these kids need us now more than ever. Thank you for your time and patience.
Thank you. Haley?
Good morning, and thank you for the opportunity to speak today. My name is Haley Dreyer, and I'm the program manager of the school-based mental health program at Catholic Charities. I've been dedicated to the mission of Catholic Charities since 2017, beginning my career as an intern and advancing through the roles as clinical case manager, clinical supervisor, and for the past year, I've had the privilege of being the program manager of the school-based mental health team here at Catholic Charities. Although I'm new to the SBMH team, I'm not new to the idea of showing up in the communities that we are in. Throughout my career, I've witnessed firsthand the profound impact that consistent relationship-driven mental health treatment can have on children and their families. Catholic Charities has participated in the SBMH expansion project since 2019. During this time, our clinicians have partnered with over 20 schools, provided thousands of individual therapy sessions, and created countless opportunities for students on and off caseloads to feel heard, seen, and valued. These achievements are the result of dedicated professionals who have invested time and effort to build trust within their school communities. I'm here today to express my concern regarding the proposed comprehensive plan that would remove community-based organization clinicians from the SBMH expansion project. The removal of these clinicians would directly impact the trusting relationships that have been established with students, families, and school staff. These relationships are foundational to effective mental health support and cannot be easily replaced. Through the SBMH program, students receive ongoing access to comprehensive wraparound clinical services in a familiar and accessible environment directly in their schools. Our clinicians support their school partners through crisis, periods of growth, tragedy, and celebration. This consistent presence is essential for multi-tiered mental health support and long-term treatment. The proposed decision to remove CBOs from school-based mental health programming in the city would have a significant and detrimental impact on the well-being of district residents. It would decrease accessibility to necessary healthcare for students and disrupt the continuity of care for hundreds of children and their families. On behalf of Catholic Charities and the communities that we serve, I respectfully request the continuation of funding for the school-based mental health expansion project and the retention of CBO clinicians in our schools. These relationships matter, and we are eager to continue supporting the mental health and well-being of our students. Thank you for your consideration.
Thank you. Dr. Morales-Black.
Good afternoon. Thank you so much for the opportunity to present and testify at this hearing. My name is Marie Morales-Black. I am the CEO for MBI Health Services, and I am the president of the board of the DCBHA, which is our provider network. MBI is a large mental health provider in the city. We provide all type of health services to over 5,000 adults and children. And we also provide services, health services, et cetera, to over 15,000 residents in the district. We're committed to providing quality of care in the district. And one of the programs that we provide since the inception is school-based mental health, where we are currently in 11 schools. This past year, we ended the school year with 127 students enrolled in Tier 3, which is the behavioral health therapy cases, serving over hundreds of direct services to those active cases. This year, we currently have about 97 cases, of which 3 of the CAFs are due. 3. I know that you will hear that CBOs are not doing CAFSs, but I know at MBI we are. During the last several years operating school-based, we have prioritized with the principal the unique needs, including the families and the school, with the families and the school personnel feedback. MBI often implements groups and Tier 1 activities based on the individualized need of the school, which at time may not have been the EBP that may have been described by DBH. I have a unique perspective because I was responsible for the oversight of school-based mental health at DBH from 2008 to 2014 when I worked for the department. And I know some of the challenges that the school-based program had, and I know some of the successes that they had. And they are a very good program. But I also believe that DC CBOs are also providing excellent care. And we all, DBH and the CBOs, have the best interests of the students at heart. And as you can hear from the numerous counselors that have testified today, we are providing some excellent work, I would say comparable to the DC clinicians. School-based was finally funded appropriately this fiscal year, which started last month. And thank you to Mayor Bowser, to this council, and to Dr. Bazran for making that happen. This is not the time to pull the plug, because now we have the ability to really focus on the quality and improvements of the programs when we're only 7 years old, not over 20. There are many reasons why I think government should not be in direct care practice. They do not have the flexibility that most CBOs have. For the parents of our students, we have been able to provide services to parents of our students, their sibling, as well as family therapy for the entire family. For example, we had a middle school student at Senton who was sleeping in class and having behavioral health issues when confronted. We sent a therapist to the school only to find out that that student was caring for a grandparent who was disabled and wheelchair bound. As a result, we were able to support that grandparent with getting home health. They received 16 hours of services from PCAs to help them. And as a result, that student re-engaged in school, have graduated, and is still doing well in high school. And we're still providing ongoing community services for that young person because they don't have a clinician in their school. As a CSA, we have immediate access to 3 child psychiatric providers, which allow for seamless continuity of care for the students. I know I am out of time, right? And so one of the things that I'll say is that I hope that the council the DBH folks that are here are really hearing the community providers. And for once, we'll listen to the voices of those that we're serving and ask the principals and the parents about the services that we serve, because we too, in partnership with them, are interested in the best interests of the children that we serve. Thank you.
Thank you. Ms. Greenspan.
Hi, thank you for the opportunity today to be here. My name is Carolyn Greenspan, and I am the Director of School-Based Mental Health at Mary Center. We have 22 school partnerships through the DBH funded program across elementary, middle, and high schools. Mary Center is a value add as a CBO, garnering deep community trust, in particular with immigrant communities. As part of our social change model, patients are referred to extensive in-house wraparound services such as navigators to support applying to food stamps and TANF, medical care, dental care, psychiatry for medication management, domestic violence services, and more. As a federally qualified health center, FQHC, costs of these wraparound services are incorporated into our reimbursement rates from Medicaid. So it also helps make the school-based work more sustainable than it would without the FQHC status. Several of our clinical managers will be submitting written testimony with more specific examples of ways that we have been able to seamlessly provide wraparound care. A few points I want to note about the comprehensive plan are places where I feel that the results and outcomes in the report are not a true reflection of Mary Center's services and should not be used to draw conclusions about our quality of care. Again, you'll find more details in my written testimony. First, the data utilized by DBH does not paint an accurate picture of CBOs in our SBBH work. For example, DBH stated CBOs have been non-compliant with completing the CAFIS consistently, which is a measure of student functioning over time. This is not the case for Mary Center. We ensure that clinicians complete the CAFIS scale every 90 days and use the scores as part of our quarterly caseload reviews. Another example is that Mary Center, along with most of the other CBOs, have not provided evidence-based programs, or EBPs. The EBPs referenced in the plan are manualized curriculums used to run therapy groups and prevention services. I want to ensure that this is not confused with the evidence-based practices that we do provide. Our clinicians implement evidence-based modalities such as trauma-focused cognitive behavioral therapy, or TFCBT, EMDR, play therapy, among others. While EBPs are useful tools to have, and we appreciate the ones that DBH has provided us, they are not always a fit for our students or schools. We have clinicians running groups that they created tailored to specific interests and needs. For example, we have clinicians using the role play game Dungeons and Dragons to address anxiety and social skills, and support groups for newcomers to the country, or people who have been impacted by immigration changes. DBH gave us the flexibility to adapt materials to our student populations, and it did not require that we use EBPs. So I was surprised when the quality of our program appeared to be measured in part by how many EBPs we used. CBOs in the city have been advocating for years to increase the grant amounts for each school placement because of how challenging it had been to do the crisis work and Tier 1 and 2 prevention work while balancing the need to bill enough to financially sustain the program. And thanks to the DC Council, we are now at a point where we can place more emphasis on the Tier 1 and Tier 2 services than before. So I am disheartened to see that it is at the same moment that DBH is announcing that it wants to bring the programs in-house. My hope is that DBH shifts gears to instead evaluate which CBO partners are the best fit, instead of doing away with the years of work that we have done to build the infrastructure, relationships, and resources alongside our school partners. Thank you.
Thank you. And thank you to this panel of witnesses for sharing your experiences and your feedback. I have a couple of questions for the providers of services from CBOs we haven't heard from. So thank you for your being here. But Ms. Greenspan, I wanted to ask, okay, so your testimony about the EBP portion of this was kind of interesting because that was a portion of the plan and the report and sort of making a presentation of evidence in DBH's mind of why the CBO model hasn't necessarily panned out. But you're saying that, well, it's kind of interesting because the whole basis is we don't want one size fits all, but then the EBP is a one size fit all, at least in the way that you're describing it.
Mm-hmm.
But that DBH did provide some flexibility in terms of whether or not you use it or not. But now, in the chart that we have, it is marking who has accomplished what using that.
Yeah, exactly. In the grant award, it says specifically that we can use evidence-based programs or clinician-created curriculums. And so we have leaned on the clinician-created curriculums because we do have that flexibility to really tailor it to our student population.
Okay. And Ms. Morales-Black, I'll give you an opportunity to participate in this part. Like, what opportunities, if any, have you all had to provide feedback to DBH of like, hey, this is great, but not really working for our student population?
About the EBPs in particular? Yes. It hasn't, I mean, we've always been grateful when they've offered them to us, but since we didn't have the impression that we were expected to do those specific ones, we haven't had that much discussion because we've been implementing successful curriculums that we've created.
Yeah, but now this brings up the question of, are other organizations using their own clinician-created ones as opposed to just not doing anything at all?
Yeah. Yes.
Oh, yeah, I don't know if Haley, if you wanted to.
Yes.
Haley, right?
The answer is yes.
Yes, the answer is yes.
And it really fit the need of the individualized need of the school. And I think that, I don't believe, and I think you've heard from previous panels, that the DBH prescribed EBPs were mandated. I don't think any of us had that impression. So we would partner with the school and the principals to provide the best interests of the school. Like, we've done some things on monthly bullies. In fact, I have a letter from one of the schools talking about how instrumental we have been, and which I've shared in my testimony and attached to for you all, Councilor Henderson, that talks about our monthly participation in bullies prevention that we provide for the school.
Yeah.
It talks about the transformative nature that we have impacted the school in regards to getting children mental health needs met so that they can return back to the learning process. But the data did not provide a space for those to be captured, although they are captured in the narrative.
Got it. So one of the things that has been a sort of a trigger here in sort of this whole conversation is around whether or not CBOs were able to find the clinicians necessary for the number of schools that you have been assigned to. That is truly a crux of it has been the workforce challenge issue of every year we are barely cracking 55% of our schools having a clinician assigned to them. What do you say to that, or the suggestion rather in this new plan that DBH can do it better in terms of recruitment and retention than CBOs? Now, and I'm also saying this with a caveat of recognizing that each of the organizations that you all work for are larger than perhaps some of the smaller CBOs. So I'm acknowledging that particular caveat.
Recruiting has been a challenge, and I will attest to that, and partly because of the funding. Because we were provided $63,000 per clinician for school-based from the grant, and then we had to earn the rest. And we still had to do tier 1 and tier 2 activities. So it had been a challenge compensating appropriately and keeping our clinicians. Although we've done a pretty good job at, our supervisor is here and he's been with us since the inception. We have clinicians that's been there for the last 5 years. So we have maintained some level of clinician stability. However, it has been a challenge. The fiscal that you just gave us last month, I think will help with that. Because the school-based funding is such that we can now keep our our LGs once they become an LI, because we can promote.
But the only way that we were able to do that in terms of funding is we had to basically acknowledge that every school would not have a person.
Yeah.
That was the only way we were able to accomplish that, was to basically say, all right, we got to abandon everybody gets a person so that we can increase the funding amount for the grants. Ms. Greenspan, I don't know if you want to.
Yeah, we do tend to hire graduate level social workers and counselors because what we pay is, comparable for that. We do struggle hiring like more advanced licenses, independent licenses, but I will say it's given us this great opportunity that we are this training ground. We provide a lot of benefits, a lot of training about school-specific work and different modalities. We have monthly consultations with our psychiatrists, a lot of group supervision, very good individual supervision. So we also offer benefits like educational reimbursement for up to $2,000. So we try to balance it out with other perks, but that has been a challenge for sure. I think an advantage is that we have maybe been like slightly more competitive than some of our partners CBOs. And so that's meant it's been a little bit less challenging for us to get the graduate licensed clinicians than it has for some of our partners.
Okay.
And I do think part of that is that being a larger organization, being an FQHC, some things like that.
Yeah. So what would you say to Dr. Price, who was here earlier? One of the things she said in her testimony is that like maybe it's not abandoning CBOs altogether, but perhaps it's streamlining, right? The ones that, fortunately, the larger ones who are stronger, who have been able to do this, continuing that work while also providing technical assistance.
Yes, to me, that does make sense. And I don't want to discredit the things that some of the other CBOs have done because I know they're doing hard work, but I do think organizations like Mary Center are really set up to do this work because of our FQHC status, our years of experience doing this work before this grant existed, and our infrastructure where we can collaborate so easily, like within Mary Center, to provide these wraparound services. Because mental health challenges are often accompanied with so many other factors, health factors that we help address.
Okay. All right.
And we welcome oversight and we welcome evaluation and making sure that we're doing right services. And I think that if we are not, then take our contract away, right? I think that that's really important, that we partner transparently with DBH to ensure that we're meeting the needs of the young people and that we are providing good outcome and result for the people that we serve.
Okay. Yes, you'll have the last word on this panel.
I was just going to speak a little bit to our recruiting efforts at Catholic Charities, recognizing we are a larger organization as well, and that you heard a little bit about our efforts from Ms. Watson previously. But we, I think, have shown today our ability to retain employees and promote upon licensure. So as we hire LGs, many of our clinicians go on to get their LIs or promote up to supervisor, program manager positions. But we really have a robust intern program that I'm heavily involved in. I started in it and have moved on to help facilitate it, and great relationships with many of the local universities and their counseling and social work programs, that we have a constant rotation of interns that are placed with our many programs for field placements. And we really are intentional about making sure that we're exposing them to all the different areas of social work. So we have that retention piece, and many of them, I think we've got 4 or 5 of them that are sitting in this room that also started as interns and have then come on as employees and have been placed at their schools for 2 to 5 years.
Yeah. Okay. All right. Well, thank you guys so much for your testimony and for being here, for work you do each and every day. I think we have one other person who's here in person, but we're going to hybrid you with the other folks because we got to keep moving. Okay. So we're moving to the virtual. So if you're virtual and you're online and you're hearing me, and you haven't done a hearing with us before, you have to affirmatively accept our invitation to become a panelist. We're going to do panels of 6. And hope so we can make it through here and just sort of telegraphing where we're going to go. Once we're done with our public witnesses, we're going to take a little break, and then we're going to come back and then do the government witness. Okay. Dr. Nora Lane, Green Lane. Oh, hold on. Gracie already went. Gail Avant, Kelly Crawford, Jessica Rice Longnecker, Carol Parks. Yeah. Marissa Perella. All right, hang on. We're waiting for people to join or seeing if they're here. So hang on one second. Okay, Janet Campbell, Nadia Gold-Moritz, okay. Jillian Buford, yeah, we did. Okay, we already called Carol Parks. Carol, we see you in the Zoom if you could just join us. All right, we're gonna stop there. Okay. All right, so Dr. Lane not here. Gail's not here. Okay, Kelly Crawford, we see you, but you haven't, oh, there you are. All right. Miss Crawford, when you're ready.
Sorry, am I first?
Yes, yes, you are.
Oh, thank you, sir.
Wait, are you speaking?
Oh, no, I was waiting to be recognized.
Oh, go ahead. It's your turn.
Oh, good. Good morning. My name is Kelly Crawford. I'm a Ward 4 resident and the parent of 3 children in public charter schools that partner with DBH for school-based mental health services. At any given moment, I'm in one of my kids' 3 toddle threads, 5 WhatsApp chats, and 1 Signal group, sometimes giggling at another parent's frustrations or sighing to myself in the daily juggle. Through the chats, I hear from parents who struggle to have their children's IEPs and 504 plans implemented, or even have their mental health needs acknowledged. Even often those needs wouldn't be acknowledged at all without the school-based DBH clinicians at our schools. As we heard today, our schools are facing a mental health crisis. Even for families with resources, coordinating care can be overwhelming. Having services delivered at school removes barriers that are too often preventing families, even well-resourced ones, from fully engaging and receiving care. DBH's model works because it places clinicians inside schools where support is normalized and students are seen in their natural environment. I can personally attest to how powerful it is when clinicians are present during lunch, pick up, drop off. They hear and see what parents and caregivers do not. Their presence builds real community within the community and allows earlier, more compassionate interventions. I personally am deeply grateful to the DBH clinicians who have supported my children. Their independence, being engaged by DBH and not the school, allows them to be effective, compassionate, and enduring supports for our students. I agree with concerns that we've heard today about caseloads. Even the best clinicians can only serve so many students. We must invest in manageable staffing levels and integration with school teams so that care remains consistent. I express my strong support for the community-based organizations being part of this final model. DBA provides the clinical baseline, but CBOs bring cultural fluency, community trust, and workforce diversity that strengthens the entire system. Together, they reach more students, especially those from diverse backgrounds, and build a sustainable pipeline of school-based mental health professionals. I offer my full support for DBH's comprehensive plan and urge the council to sustain and expand this work so that every child in DC can access compassionate mental health care right where they learn. Thank you for your time and for your commitment to our children and our families, and thank you for the opportunity to share with you today.
Thank you. All right, Jessica, who's here in person?
Good afternoon, I guess now. Thank you for the opportunity to address you today. I'm Jessica Rice. I'm the Director of Behavioral Health at LAYC. So we're one of the unique community-based providers of school-based mental health in DC. We're a relatively small provider, in part because we're committed to ensuring the flexibility and responsiveness of our services. And the DBH plan does lay out the need for this flexibility and for addressing specific school needs, and they also emphasize accessibility. And I agree that all of these are foundations to successful school-based mental health, and I would suggest that in order for those things to happen, community trust and really hearing community voice and giving choice is necessary. So I'd like to share how we build community trust and how we focus on mental health, not just as a model of teaching standardized skills, but how LAYC clinicians use our positive youth development model to reinforce and support the student community engagement and build resilience. So like you just heard, DBH has used evidence-based practices as a measure, despite the benchmark always being a broader prevention and early intervention benchmark. It's not what's captured here. We've always felt like we are really successful. And I'll move away from my remarks just to say that we're in many schools with really high need that have DBH clinicians or have a lot of school counselors. And we still have full caseloads and get so many referrals. And part of that is because we are often, as the community-based organization, tasked with those kids that aren't being met by those standardized practices and the other services, right? So we're very intentionally taking on the things that need to happen to complement those, right? So instead of just joining and doing an evidence-based practice, which we certainly do a lot of the evidence-based practices, we then also create a curriculum around the kids who are, chronically truant, right? And we sit in our high school and bring those kids in to actually come in. They're not gonna come if we're just gonna lecture them, right? We, create systems where older kids in the elementary school are our ambassadors for mental health. And none of that is captured in this report. We've always felt like our relationship with DBH was a positive one. We've been able to go to them and say, like, this is why it's different, right? This is our work plan with the school, and this is the specific needs of the school, and this is how we're complementing the work, and gotten positive feedback around that. So it's been hard to hear that they felt like there was no value add. I would just say that, community trust has been a big thing for LAYC, and really kind of working with the communities where we're serving to identify the needs and really hear their voice and build that trust. We've got 50 years of doing that, and being able to bring it to school-based mental health has been a really positive success. Thank you.
Thank you. Carol Parks.
Good afternoon. Can you hear me?
Yes, sir. Good afternoon.
All right, great. Good afternoon, Councilmember Henderson. My name is Carol Parks. I am the Chief Executive Officer of Hillcrest Children and Family Center. Hillcrest is 210 years old. So we've been providing service in the District of Columbia for that long, providing quality, critical services to children, families, and schools across the district. Currently, we are in 29 schools and with 25 therapists and 4 prevention specialists. While I want to acknowledge the intent behind the comprehensive plan for school-based behavioral health expansion grant in the report itself, which is lofty goals of ensuring that every school has access to behavioral health support, is both timely and necessary. However, the structure and the funding of this initiative have not positioned CBOs for long-term success. Over the past 6 years, this program has relied heavily on the dedicated, flexible, and resiliency of CBOs, with limited systemic support from the Department of Behavioral Health. Despite many years of ongoing feedback, and we've had challenges with recommendations that we've made to implement. Funding continues to remain the greatest challenge. Unlike other districts or jurisdictions where models are fully funded, DC CBO clinicians are financially constrained to provide only Tier 3 services, restricting somewhat of our while we do prevention and intervention Tier 1 and Tier 2. We believe that the Department of Behavioral Health employed clinicians operate under a different standard with limited or small caseload or targeted caseload or outreach requirements, which is they don't provide during the summer or none of the financial pressures that CBOs face. Now, the good news is we believe, and we're very happy to see that for FY26, this is the first time that we've got close to adequate funding for CBOs. And we appreciate and commend you and the council for that. However, despite these barriers, Hillcrest has delivered meaningful results. We've operated over 20 programs supporting students, families, and schools, often at the no cost when reimbursed if available. We've created family wellness spaces. We've created large-scale family engagement events and delivered evidence-based services directed in schools, including trauma system therapy and trauma-informed care. However, we are deeply concerned about DBH plan to fully operate of a school-based behavioral health program over the next 2 years. The plan fails to highlight the results of CBOs in its DBH applicants. We're concerned about the transition and the serious negative impact it will have on CBOs, disrupting staffing, programming, and longstanding relationship with schools and families. We do not believe that a one provider model is the best for our community, and we encourage you to reconsider that plan. Thank you so much for giving me the opportunity to testify.
Thank you. Marissa?
Thank you. Good morning, Chairperson Henderson, and thank you for your thoughtful questions during today's hearing. And thank you for the opportunity to testify today. My name is Marisa Perella, and I'm a DCPS parent, a clinical social worker, and the founder and executive director of the Momentum Residency, which is a new initiative that addresses school mental health workforce recruitment and sustainability. I've played an active role in conceptualizing and implementing school mental health programs, policies, and practices in DC through my former role as the original founder of the Mary Center School-Based Mental Health Program, was on the original School Mental Health Task Force, and in founding Momentum. I'm here today to express my grave concerns about this new plan to transition behavioral health services away from CBOs to a DBH staffed model. The plan is built on a flawed foundation, and the claim that this approach will produce better outcomes at lower costs just lacks supporting data and creates a false comparison. More troubling is what the data actually tells us. DBH was at risk of losing the school mental health program due to poor implementation, and now has created a corrective action plan that doubles down on reliance on internal DBH systems that were not serving us before the creation of the original expansion. These risks include, and were spoken about today, disruption of student and family relationships, disruption of existing and successful partnerships, and alienation of community-based organizations from children and families. These are the very issues that DBH raised when their program was threatened to be replaced by CBOs in 2017. The plan claims to move away from a one-size-fits-all approach, yet proposes centralizing all the services under one agency, which is the very definition of a monolithic approach. CBOs bring diversity of practice, which we've heard a lot about today, cultural competence, and community connections that a single government agency cannot replicate. They also bring more than simple evidence-based practices to the work. They bring flexibility, family services, creativity, social service connections, community psychiatry, and linkages to entitlement programs, and perhaps most salient now, filling gaps for communities who are currently losing their entitlements. The plan also presupposes that there will be sufficient licensed clinical practitioners to fill positions at DBH while evidence is to the contrary. There's a national workforce shortage in school mental health. CBOs provide essential clinical supervision and training environments for emerging professionals. The plan provides no workforce or financial analysis comparing the current hybrid model to full DBH implementation. Remaining questions are, what are the real costs of recruiting, hiring, training, and retaining a DBH-only workforce in this competitive market? What's the cost of losing institutional creative knowledge when experienced CBO clinicians are displaced? What's the cost to families and students who've built trust, particularly ones that provide culturally competent care to specific populations? These questions remain unanswered. So I encourage the council to reject the plan and encourage these more creative solutions that have been proposed today. And there's more in my written testimony. Thank you.
Thank you. Janet?
Hi, good afternoon. My name is Janet Campbell, and I am a licensed clinical social worker at Community of Hope. I have been working at Roosevelt High School since 2023, but I've worked at Community of Hope and with youth in Washington, D.C. since 2017. Roosevelt High School has nearly 1,000 students, and I am the only member of the mental health team that works exclusively with general education students. As a result, my school has asked me to focus on providing Tier 3 services. I currently have 18 students on my caseload that I provide weekly individual therapy for. I also oversee an MSW intern who has a caseload of 4 students. In addition to the students on my caseload, I also see a number of students for walk-in appointments, as we've learned many other clinicians do as well. Most of the students that we encounter have experienced some form of trauma, from sexual abuse to homelessness to community violence. However, they are resilient, creative, and they have big dreams for their future. In addition to providing individual therapy, I have designed and implemented Tier 2 groups. One of the groups, a social skills group that is designed for multi-language learners who do not speak Spanish, was designed to increase connection among students. Participants in this group were from China, Bangladesh, Ethiopia, Haiti, and more countries. Even now that the group ended, those students still choose to meet in my social worker suite and eat lunch together. The other group is a grief group for students who have lost a loved one. This group is so popular that students have come to me this year and requested to join it. Although these groups are not the evidence-based curriculum that is provided by DBH, they do directly meet the needs of my school and its students. Community of Hope's partnership with Roosevelt has allowed me to provide holistic services to students and their families. I work closely with our psychiatric team, who are able to meet with and provide medication to interested students within 2 weeks of my referral. I have also partnered with our substance abuse clinicians, who have provided tailored treatments to students who would like to address their substance use. I know that Community of Hope is an asset to Roosevelt High School, and I know that it's an asset to the overall school-based mental health program. I hope that DBH will reconsider their plan and allow us to continue our vital work in the future. Thank you.
Thank you. And thank you to this panel of witnesses. And I'm saying that because I don't think that Nadia or Jillian have joined us. Okay. So thank you so much to this panel of witnesses for your insights and thoughts on this. I was wondering, and I'll open this up to, any of the providers in particular, but if you want to speak to how you were engaged in the creation of this plan, if at all. Anyone who wants to?
The creation of the most current plan, Councilmember?
Yes.
Yeah, I like someone else who spoke earlier, there were 2 meetings that you could engage in, and similarly, that was all we were offered. 2 online virtual groups, feedback sessions.
Mr. Parks?
Same, I would say the same, and we did have individuals who did participate, but it was only 2 opportunities for a plan that is really going to, what I would call, radically change the system of care. So I just don't believe that there was as much engagement in the community as well as providers that was necessary to come to that kind of a plan, especially when you consider the plan is proposing over the next 2 years, with the 1 year, next year being only 4 CBOs, and then the next year after that being 0. The amount of obviously it would have been, we did not know that that was part of the plan. It just seems like the information was not communicated to that level. And it would have should have been a lot more focus groups, a lot more engagement, a lot more community engagement as well, before something like that would have been recommended, which is, as I say one more time, it's going to radically change the system of care for school-based services.
Okay. All right. Oh, Jessica, did you want to add? Or no? Okay. All right. This is the trouble of being almost 3 hours into a hearing. You've heard a lot from folks. So I want to thank this panel of witnesses for being here. And if we don't have your written testimony, if you could certainly provide it to us for the record. We're going to go to our last group, and then we'll take a break. Mariah Burke-Rains, Xavier Smith, Arlita Idrissa, Elsie Orlana Rodriguez, Tia Powers, and Terrence Campbell. Again, you'd have to affirmatively accept our invitation to become a panelist. Okay. Mr. Campbell, we see you, but you have to accept our invitation to become a panelist. Okay, going once. Going twice. Okay. All right. So we're gonna take a 5-minute break. And when we come back, we'll go to our government witnesses. The individuals who we've called are not here, and the one person who is hasn't accepted. So we're gonna take a break, and then we'll come back for our government witnesses. Thank you. All right, we are back. We have our government witness, Dr. Barbara Bazaron, who's the Director of DC's Department of Behavioral Health. Before we begin, I have to swear you in. And anyone who might speak on behalf of your team, if you could raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. All right. When you're ready, you can begin.
Okay. Good morning, Chairperson Henderson, council members, and council staff. I'm Dr. Barbara Bazaron, Director of the Department of Behavioral Health. With me today is Dr. Megan Sullivan, Deputy Director of Child, Adolescent, and Family Services. I'm pleased to testify before you today on the fiscal year 2026 School Behavioral Health Program Comprehensive Plan. The plan strengthens the school behavioral health program model and ensures that the district school-based behavioral health program is responsive to the needs of every student. First, I want to thank the leadership and staff of our CBOs and our DBH staff who have worked tirelessly to provide the range of services to support our children, youth, and their families. For 25 years, since 2000, DBH has led the development and implementation of the district's behavioral health program in public schools in partnership with OSSI, the Deputy Mayor for Education, the Chancellor, and the public charter school leadership. DBH has adopted the public health framework, which includes prevention, early intervention, and treatment services to meet the needs of all students. Today, services are delivered in 158 schools by licensed behavioral health providers employed by DBH and community-based organizations through a grant program. In 2012, the DC Council adopted, and then Mayor Gray signed the South Capitol Street Memorial Amendment Act, which required the mayor to submit a plan to make behavioral health services available in every public and public charter school by school year 2016-2017. At that time, there were 59 mental health clinicians hired by DBH, supporting about 1/3 of the public schools, either full-time or on a part-time basis. The new legislative mandate was interpreted to mean that at least one clinician would be placed in every public school. Led by the then mayor for Health and Human Deputy Mayor for Health and Human Services, DBH adopted a phased-in expansion to all schools starting in school year 2018-2019 with scheduled completion in 4 school years. Rather than hire additional DBH clinicians, the expansion was implemented through a partnership with community-based organizations selected through a competitive process who would contribute to the funding for the program. The expansion started with schools identified with the most needs in cohort 1 and was completed with cohort 4 in SY 21-22. Since then, the number of schools with at least one assigned licensed clinician has nearly tripled to 158 public schools. The expansion was in its first year when the COVID pandemic changed our entire environment. Despite the new challenges of remote learning and increased workforce shortages, DBH continued to add new schools and build an infrastructure of grant management, technical assistance, oversight, and a learning collaborative. However, there is no doubt that the changed conditions during the pandemic slowed the expansion and delayed a comprehensive data-driven evaluation of the effectiveness of our work. Key implementation challenges emerged, which includes 1, increased workforce challenges during COVID. 2, community-based partners with limited success identifying and enrolling students in treatment, which affected the full model implementation. And 3, insufficient billing by the CBOs to generate the agreed upon portion of the salary of a clinician per the funding model. To address this challenge with the expansion, DBH piloted new models of services delivery beginning in school year 23-24 to give more flexibility in the delivery of care. While stressing the importance of on-site clinicians, DBH supported a hybrid telehealth model for youth in 3 high schools and schools with adult learners. In addition, DBH provided funds directly to public charter schools to directly hire clinicians and supported a cluster model where services were provided by a team of clinicians to multiple schools. Due to the small number of schools participating in pilots, there was not a significant increase in the number of clinician-delivered services. However, during this year, the telehealth pilot will be continued to obtain additional data regarding the value of this innovative approach. The Coordinating Council, CBOs, City Council, and outside advocacy groups expressed concerns regarding the school-based behavioral health model, specifically focusing on the vacancy rate, the funding model, and the lack of flexibility in service delivery. In order to address these concerns, DBH collected data and feedback from clinicians and stakeholders to inform and guide the development of a new model. With the support of the Coordinating Council, education partners, agencies, CBOs, school-based behavioral health experts, and through reviewing data from multiple sources, DBH created the FY26 School Behavioral Health Program Comprehensive Plan. Our plan outlines strategies to strengthen the school behavioral health program model and ensure that the district's school behavioral health program is responsive to the needs of students. The plan details steps to enhance DBH's ability to be responsive to the individual needs of the school while increasing access to behavioral health services for students. And that is our goal, access to all students. To achieve these goals, the plan incorporated a phased-in implementation approach, outlining key milestones and strategies that will guide DBH in strengthening services, expanding accessibility, and ensuring responsiveness to youth's behavioral health needs. The school behavioral health program is led by the following guiding principles. The public health model will continue to be used as a framework for the program. Not all schools need or will receive one full-time clinician. The focus is on students having access to behavioral health services. A continuum of behavioral health professionals will be utilized to provide care. Some prevention services will be provided by unlicensed staff with training in mental health and health education. Treatment services will be provided by licensed clinicians, including professional counselors, social workers, and psychologists. The school-based behavioral health services will be provided through 4 models: a full-time clinician model, a part-time licensed clinician, a cluster model, which includes licensed clinicians and prevention specialists providing services across several schools, and a telehealth service model. DBH will initiate a phased transition to bring services in-house starting in school year 25-26 and reaching full in-house implementation by school year 27-28. To ensure success with implementing the timeline, DBH has outlined the following milestones. We have awarded 12 CBO grants and 3 LEA grants. These grants have been awarded. We've hired 24 new FTEs within DBH to support the provision of services. That's in process. Contract with an expert to identify the elements of an effective school-based program by examining the performance of both CBO and DBH clinicians. Increase the monitoring of compliance with the performance metrics for all providers and clinicians. Monitoring will include increasing the number of site visits and analyzing the reviewing utilization and benchmark data on a monthly basis. Select a maximum number of CBOs to continue providing services in school year 2026 to 2027. Selection will be based on performance and compliance with implementation of school-based behavioral health services. In the remaining CBO contracts and grants on September 30th of 2026. During school year 26-27, DBH will implement services using a hybrid model. Services will predominantly be implemented through DBH hired clinicians. However, some schools and some services will continue to be implemented through 3 or 4 high-performing CBOs. DBH will hire 59 additional FTEs to provide services to schools previously serviced by CBOs. Continue to monitor CBO and DBH compliance through site visits and monitoring of performance on school-based behavioral health benchmarks. During school year 27-28, the school-based program will transition fully in-house, with behavioral health staff being employed and managed by DBH. Milestones for the 27-28 school year include hire 30 FTEs to provide services at schools previously covered by CBOs. Based on the results of the environmental scan data and resource allocation, utilize a combination of licensed and unlicensed staff to provide services across the public health continuum. Continue to monitor data to ensure compliance with implementation of the model and the program benchmarks. Achieving these milestones over the next 18 months, DBH will ensure a smooth implementation of the revised service delivery model while phasing in services within DBH and expanding access to behavioral health supports. This structured, phased approach not only lays the groundwork for enhanced services, but also provides a new framework to support the behavioral health needs of our youth in public schools. Madam Chair, we appreciate the work of the committee and especially acknowledge Marsha Huff, who participated in the planning meetings. We look forward to our continued work to support the health and well-being of youth in the district. I am ready, along with my colleagues, to answer any questions. Thank you.
Thank you. Thank you for being here and for your work. I want to note we've been joined by Councilmember Zachary Parker, who's a member of this committee, Councilmember from Ward 5. Love when my colleagues come to hearings. So we're going to do 10-minute rounds. And so let's just jump right in. So Dr. Bazran, I want to give you an opportunity to describe a little bit of the process for developing this comprehensive plan. At the offset, did you all consider ways of how to support and improve the CBO participation in the program? Or from the offset, had you already determined that you wanted to bring this program in-house?
Well, thank you for that question. You may remember that we did have a community of practice that we invested in heavily to provide technical assistance and support to CBOs to ensure that they had the knowledge, skills, and ability to address the requirements of the program. We did not, quite frankly, realize a lot of difference as a result of that effort, but that was one of the things that we did. In addition to that, we also, our DBH staff have always been available to provide support and ongoing oversight and supervision. So that was one piece of it. The other thing, as you know, we have had many conversations about the model, many conversations about what was working, what was not working, and why. And we have developed in partnership with the CBOs as well as the School Coordinating Council strategies for addressing those issues. One was the whole series of pilot efforts that we thought might help us address particularly the workforce shortage and allow us to have greater coverage. What we found is in implementing those efforts, there wasn't a lot of uptick, even though those were the things that people said we needed to do. And as you know, that resulted in many of our schools not receiving the services that were required under the school-based behavioral health program. We meet on a monthly basis with our school-based coordinating council. I actually co-chair that meeting and personally show up for each one of those sessions to hear what's happening and to hear and learn what we might be able to do to improve performance. And so we have the ongoing conversations regarding this program very specifically.
So I mean, I appreciate all of that, but I
Right.
guess even all of that work and sort of the community of practice and the engagement piece, like heading into this plan, had you guys already determined you think it was best to bring it in-house?
As we looked at the plan, one of the things we did is we looked at all of the data that was gathered, including data that was provided by the CBOs around their benchmarks, success, and their data. The environmental scan, which included specific interviews and focus groups, which was another way to gather the data. And then we also had the public meetings, which you've heard about, to get information. We also did work with a couple of school-based behavioral health experts, one of which was Dr. Olga Price, to get their individual input in terms of what we needed to do moving forward. And so with the limitations of time to develop the plan, we did certainly reach out and hope to do more of that in the future.
Okay. So, sort of really answer the question, but I guess you've landed where you have landed. So how you got there, I guess, it's important, but not necessarily for this conversation. But let's talk a little bit about the environmental scan. It excluded 29 schools. Are you all still working to obtain data from those schools?
I'm sorry.
The environmental scan didn't include information from 29 schools. Are you still working to get information from those schools?
Yeah, so I think to give a little bit of the background, and we shared this in the comprehensive plan, our staff at DBH reached out to each of the 254 schools, and as you can see, 225 of the schools participated and were interviewed. And so it's almost 90%, about 89% of the schools did participate and provide information. As you can see here, some didn't participate because they declined. They didn't want to respond to multiple requests. We have worked with the Alliance and Ms. Travers, and we're trying to get some of that information. And as we mentioned before, this is going to be an ongoing process. Obviously, we did this summer. We collected the information, but as we talked about previously, the landscapes of schools change.
Yeah.
And so
let's talk a little bit about, like, in terms of the environmental scan, what kind of questions did you ask? There had been requests that you all release the raw data information. Is that something that you all can commit to?
We, so I can answer the first question around the types of questions. So we actually did send those questions to the behavioral health coordinators prior to the interviews because we wanted them to see what the questions were. We also worked with CLC on developing the questions, and they provided some information back to us. And so while we 100% reached out to the schools and did all of that work, it was in collaboration. I mean, we've been talking about this for a while. So some of the questions really looked at the landscape of the school. What are the type of providers in your building, both school hired, DBH funded, as well as if there are other community-based interventions that are in the building? Hours, part-time, full-time, who are you providing services to? So gen ed, special ed, what types, how much time are you providing? Are your caseloads full? So looking at that, we also asked the leadership and the coordinator, what are your gaps in the buildings? And so looking at, are there things like, are you needing additional mental health treatment services? Are there tier 1 services that you need? And so really looking at what you have, who are those people, what are they providing those services? And then what are your gaps?
Okay. Is this data confidential?
The data's, no.
Okay, so would there be any problem for you guys to release the raw data information? I mean, I think it actually would be helpful just in general.
Sure,
and it's sort of the perspective of like, who's in the building?
Right.
And to have a central depository of like, how many social workers are in a building? How many school psychologists? How many therapists? Who's paying for them? That kind of thing. I also feel like that's something that we should be doing every school year though.
Yeah, we plan to do it annually.
Okay.
And that's a part of our process. And I agree, because one of the things that we really had to consider is that there are a number of other mental health professionals in the building. However, they're used in different ways. depending upon the concentration of young people with IEPs in the building, and other needs that the building leadership says are those people need to fill.
Well, I think it's super helpful. I mean, I'll tell you, we probably have some of this information from DCPS because we can probably figure that out. The charter schools, black box. So if you guys got it,
we have it.
Share it
We can
with
share
us.
what we have, but that was important to note because we're talking about how that team together will provide services and supports for those young people. And what are the needs? Where are the gaps?
So what would you, I guess, what's your proposed sort of cadence of timeline? I talked about earlier, right? So like DC Health, when they're doing the school nurses, they're evaluating over the summertime how they're going to assign nurses or technicians, et cetera, based off of the data that they're getting back from the student help forms, right? How many students require medication? How many students does X, Y, or Z? So they're having a fresh look, and then they calibrate at the beginning of the school year in case some new student has enrolled that they didn't have on their system. How are you all thinking about that cadence?
Well, I think we agree with that, first of all, because things do change. Having been a building principal, I know what changes in the school population from year to year. And so we do plan to not only do it annually, but also to meet with school leadership to get some sense of what they think some of the needs are prior to the next school year. So, in that early summer period, that June, July period, so that everybody can plan appropriately as we move into the new school year.
Okay. In terms of data on student populations that schools have identified for needing additional resources, how would you address that?
Go ahead.
Well, again, I think also the important thing to think about is this is one piece of the puzzle, right? And so this is very important information that we haven't necessarily had about the landscape of the school. Our intention is also to gather information and collaborate with the school principals and leadership, as well as the education partners and the providers in the building to assess resource allocation, right? And so the leader may be saying, yes, we need an additional clinician, right? But we also are looking at the data and saying DBH funded clinician doesn't have a full caseload. And so looking at and using that information to then move forward and make those decisions. So we often hear that additional things are needed.
Well, yeah, I mean, I don't know a principal who would turn away
Exactly.
qualified help.
Right.
Qualified, important in terms of that. But I think then, and let's tease this out in my next round around this concept of like just the focus on the caseload, because what we heard from some of the folks who testified today is that yes, they're doing treatment on a certain number of students, but that is not the full basis of the presence, nor should it be our determinant of what is success and whether or not you're actually being successful as a CBO in that building, because prevention is important. But I'm over my time. So,
yes,
Councilmember.
We agree about prevention, and we
Okay.
really want to see prevention so we get upstream.
Councilmember Parker.
Good to see you, Dr. Bazaran.
Good afternoon.
I'm always excited when it's a DBH hearing. Before I dive into my questions, I want to just level set. So I think Councilmember Henderson asked this, but I want to ask it again. What was the reason for the transition to bring the program in-house?
Well, I think that there were a number of reasons. One, we couldn't do what we've always done, because then we would still be faced with some of the same issues. We wanted to make sure that we had a way within our financial means to cover all of the schools so that we could increase access across the board, so that all young people had access to care. That was one thing. The other thing is we wanted to really look at quality of services specifically, and we do have very positive feedback from principals and others around the quality of the services that are offered within DBH. Supervision. We provide very, very intense supervision of all of the clinicians. We monitor those services very, very closely. We have the data in our system so we can track it over time, as opposed to when you have 13 different CBOs, everybody has a different EHR. We have some of the stuff, we don't have stuff. We have to wait for people to give it to, that's.
So it's fair
another
to
thing.
say access, quality of service, and coordination.
And coordination.
At the height of the previous model, how many schools were covered under the school-based behavioral health program?
I think the highest. that
Even
we
if
were
you give
ever-
a percentage.
About 70% was the highest that we were at.
Got it. Okay, now switching gears. So it is my understanding that the school-based behavioral health program is seen as the main vehicle to provide mental health, behavioral health support to young people in the district. Is that fair?
That's fair to say, in partnership with the other members of the mental health team within those schools. So we don't work in isolation. There's actually a team that works together. Many of those team members, some of those team members are hired by the school, and together we, for example, developed a school strengthening tool.
And the
Yeah.
hope is, I'm assuming, as you bring this in-house, then instead of 70% of schools, 100% of schools will be covered by what date?
By school year 27, 28.
And I recall in the fiscal year 26 budget, the mayor cut CHAMPS, and one of the justifications provided was, well, we have the school-based behavioral health program, and young people receive the majority of their support in the school environment where they spend most of their days. How do we square those two facts, that we know not all schools had coverage, we know all young people didn't have access, we know all young people, even in this new model, won't have access until, at best, 27, 28 school year?
Perhaps we should step back and.
What I'm getting at, and I'll just
Yeah.
be explicit. Right now in the city, we're having a lot of discussions around young people acting out, engaging in behaviors that are not productive. The council just took action yesterday to extend a curfew where the mayor seemed to suggest that it was our fault that they were running around Navy Yard, which I think is ridiculous. But the main tool and vehicles to provide at least behavioral health and mental health services to young people has been shoddy at best. At best, it's only covered 70% of schools. And anecdotally, I think anybody would say young people just don't have as robust resources as they need. So what I'm getting at is, we know the old system never maximized its potential. We're in this transition phase. At best, you're saying we should scale up in school year 27, 28. How, and I have questions about the transition, but how can we square this moment that we're in now, given that so many of our young people need this support?
Yeah, and I think that's where we're at. It's really about access to all, but moving there quickly, right? And so as we've talked about, the one size fits all doesn't work. And so in this new plan, we're looking at four different service delivery models, right? And as moving it in-house will allow us to the flexibility of providing the resources in the appropriate level at each of the schools. So we'll be able to, instead of saying one person, one school, right? We'll be able to expand faster into these other buildings. So let me give you an example. This school year, we're in a hybrid model. We're essentially bringing on 24 DBH hired clinicians. Those clinicians will be able to provide services in 54 schools this year, right? And so then as we transition into the next year, we're bringing on 59. We're reducing the number of CBOs and using that money that we're currently paying $120,000 per one clinician, bringing that in-house to DBH, hiring those 59 clinicians, and we'll be able to provide services in, I want to make sure.
And what contingencies are in place so that we're not here next year and you're telling us we couldn't hire the people? We have the salaries, we have.
And so we're not going to lie, workforce is a challenge, right? This is why we're here. Well, some of the things that we're currently doing, our history of being able to hire DBH clinicians is strong. We just had a cert of 21 clinicians for positions. We made offers to 7 of those individuals and are bringing them on board. We've also done some widening of our reach. So previously, you may know this, that DBH only hired independently licensed social workers. We now have graduate level social workers, so we're widening, and we are currently in our plan for this year to bring on these other individuals. We are widening it to LPCs or licensed professional counselors.
A school leader literally texted me, so I'm assuming they're watching this. And they said, we are deeply concerned about this DBH plan. We believe even fewer students in schools will receive support. Literally every school leader asked, and then standout schools hearing happening at the same time said why they needed more mental health services for their students. This plan itself will result in fewer schools with supports. How might you respond to that?
I don't believe that's the case, I can tell you, because right now we know that we are not getting traction in terms of hiring additional staff with the current model. So we have to do something different. And we have to look at a more flexible coverage system so that we more directly meet the needs of the schools.
And I know this came up, I want to say it was DC Prep, not to name, that wasn't the school leader, by the way. But this is another issue that they wanted to do their own in-house hiring and planning and was saying, DBH, can you just give us the money so that we can strengthen our own pipeline? And it seemed like you all put out an RFP, but no one took up that opportunity, but that there were other barriers to allowing them to do that.
No, as a matter of fact, we did put that out as a solicitation based upon the feedback that we received from the schools.
And
from the charter schools. And we got very little uptick, and we did it more than 1 year.
And will that level of flexibility be allowed in this current transition plan where schools may want or have the capacity to build their own in-house program? Is that going to be allowed as an extension of you all bringing this in-house?
That's not a part of the plan as it currently it has been written, but certainly we're always willing to have a discussion.
Okay, I only have 1 minute and 20 seconds. What will the evaluation process look like to determine what CBOs should continue with their work with DBH?
Metrics.
Great question. We have benchmark metrics that we use. We also have, which look at, as Councilmember Henderson mentioned, not just treatment, but prevention, early intervention, making sure that they're implementing the full public health models. So we have currently instituted kind of a scorecard looking out every month at where's each clinician, and it rolls up to the CBO. And so how are they doing? So performance-wise there, some of our CBOs also mentioned CAFIS and PACFIS, which is our functional assessment tool, which is really looking at the kids in treatment. Are they getting better? So you're seeing them, but are we seeing reductions in these behaviors or increases? So we'll be looking at those. We'll also be looking at how they're implementing the public health model as a whole and how they're integrating into their schools, as well as we strongly believe that supervision is a strong component. So we will be looking to ensure that they're providing those as well.
Right. The other thing is there's some other things that we'll be looking for. I think somebody mentioned earlier about the needs of teachers and adults in the building. And so one of the metrics is to provide workshops for teachers so that they have some sense of how to determine when they should be referring young people to the proper supports and giving them some of the tools they need around prevention.
Understood. I'm over time. If I could just make a quick recommendation, it may be valuable to do some outreach and socialization with school communities, given that there's clearly some anxiety about what is detailed here. Thank you.
Certainly.
Thank you, Councilmember Parker. I'm going to pick up on that just in terms of what did stakeholder engagement and outreach look like in terms of the process. We heard some testimony from today where even there were some critiques of the 2 public sessions that you all held on August 27th and September 4th. this plan doesn't, well, the plan that we have didn't even sort of reference back to the conversations or things that might have been raised during that time. So I didn't attend the meetings, but let me ask the question, was it a, hey, what ideas do you all have? Or was it, hey, this is our idea DBH, and what feedback do you have?
It was presenting the ideas and the recommendations that we had and asking people for feedback or for whatever else they might be able to support.
Okay. Okay.
So it's an interactive kind of process.
Okay. Was anything that was collected during that time incorporated into your thinking?
Yeah.
I think absolutely. I think some of the information around billing, I should also mention outside of those stakeholder meetings, we also met, Dr. Bazran wasn't part of these meetings, but Erica Barnes, the director, and myself met with the CBO execs. They meet monthly. And so we specifically at that one, we did talk about the plan, but we specifically talked about billing. We talked about some of the barriers. And so there was conversation back and forth about that. In the stakeholders meeting, we talked a lot about the environmental scan, lots of questions about that as well. I would also add in the coordinating council, we, I think, designated at least 1.5 sessions on the environmental scan and feedback. And, lots of concerns around only using that data as one piece of making a decision about what a school is going to get. So, I mean, we definitely incorporated that into.
And also we spoke and worked very closely with DC Public Schools school leadership, as well as speaking with the director, the state superintendent about this plan and making sure that we had kind of feedback also from that group.
Okay. I was going to ask about that, but I mean, it's fine to talk to the chancellor, but did you talk
We
to
also
principals?
talk to people beyond, for example, what is Deirdre's role? We talk to people also at the
Principal,
direct
no, I mean,
service
to
level.
Councilmember Parker's question, did you talk to school leaders, principals who are in the building every day?
I personally have not talked to principals, but people underneath us have conversations. And I would also add that at our monthly supervisor meetings with the CBOs, that information comes through. We also have conversations around resources regularly. And as you know, at the end of school years, there's often changes. And so Dr. Sharnita Scott has had lots of conversations with principals about shifts in resources and things like that.
So what's your response then to the testimony today from public witnesses who sort of uniformly said they were left out of this process? Or rather,
I don't know.
the process had window dressing of a process, but it wasn't really a process. There wasn't an opportunity to meaningfully engage.
The other thing too is I think the one thing that we should emphasize is that this is our plan. And there will be opportunities for input as we move through our planning process. And so there certainly will be other opportunities for that type of discussion. We had discussion, but there will be more opportunities.
Okay. The plan doesn't reference back to the child trends evaluation, which recently occurred. My understanding of the child trends evaluation, they found that schools and families were satisfied with the CBO clinicians. How did that go and play into effect or not?
The Child Trends, I think you know this, was our evaluator for the school behavioral health program a few years ago. There has not been a current report that I'm aware of. They may be talking about the fiscal impact report, which was obviously made available a few months ago. I would just speak to, I don't think that we're necessarily saying that the principals or staff are dissatisfied with CBO clinicians or the services. I think our point is that we know we need to do something different. I mean, we've sat here and had these conversations. And so our plan really tried to outline, how do we move this forward and move this forward quickly? And so I don't disagree that they're providing quality services and obviously in some of their school buildings.
Okay. I mean, I'm okay with we got to do something different, but if we're going to do something different, we got to bring people along with us so that implementation of that difference actually works the way that we want it to work. And that there isn't a massive amount of pushback because we didn't do the communication up front. And I hate to continue to do the parallel with school nurses, but when we transitioned school nurses in that first year to a cluster model, it was a cluster, fill in the word, partly because there was that lack of communication with school leaders and parents about what this was actually going to look like on a day-to-day basis. So I'm trying to avoid that second time around, if that we can truly do some real expectation setting with folks around what does this look like? It's going to look different than it currently looks like today. You might not have the same provider that you have today, but here are our goals, right? We are desperately trying to increase access because we know that the need is there. We are trying to meet some of the challenges that we have in terms of the workforce shortage and the financial limitations that exist in any sort of environment. And so this is our best effort to do those things. You get me?
I think that's all, well received, and I don't disagree with that.
Okay. So in terms of next steps for kind of advancing this plan, you talked about we're going to keep talking about it and those kinds of things, but like it seems to me that a next very large flashpoint here is what happens with the budget. Is that accurate or?
In terms of,
in your report, you're already for next school year. So we're in 25, 26. So for 26, 27, that would be the start of the transition. If you don't or are not able to start hiring some of those new FTEs, right? That's what I'm saying. Like it kind of hinges on next year's budget.
well, first of all, we have planned the program strategy around the budget that we currently have, the amount that we currently have, and how we can best utilize those resources. And so that is our plan. We also are now in active recruitment so that we can get people on board as quickly as possible.
Okay. So let's talk about that just from a math perspective. How much money is the school-based behavioral health program today?
25.4 million.
You said 25.4 million?
Yeah.
Okay. As you are budgeting for these new FTE positions, obviously they're not all clinicians. So let's go through the list here. So a prevention specialist, what is the envision of like where that position would be on a salary scale?
I'm not sure if you want dollar amount or like
the dollar amount.
Like on average, what?
Less than the clinicians.
Yeah, what would the range be?
Hold on,
It's about 60,000.
about 60,000. So 10 prevention specialists, which we allotted for would be 80,000 with the fringe benefits. So it's probably about 65 plus.
Okay,
50.
so 80 with fringe.
Yes.
Okay. All right. I guess for your clinicians, what you have a step scale based on experience or licensure? Okay, so what are we thinking in terms of like if I'm at
It's about 120 with fringe.
LGS?
It's about 120, yes.
For all of them?
With fringe for a license.
Okay. 120 with fringe. And how many would you say of those positions you would need to make it work?
And we have
For fiscal year 25, sorry, I know we keep going back fiscal
I know.
year. It's 24 FTEs. It would be 15 licensed clinicians, 6 prevention specialists, and 3 program monitors. And so we currently, I think we shared this, but just to reiterate, no additional funds would be necessary.
Okay, can you send that to us?
Sure.
Your breakout, because you sort of said a lot there.
Sorry.
But that's only for what is envisioned for 26.
Yeah, we actually have a 3-year plan.
Okay.
That we can share with you that really lays out what the cost and
Yeah.
how the cost will be allocated over that time period.
That would be helpful. And I'm not doubting that
Mhm.
you can make it work because we were able to do it with school nurses because we were able to save on some
Yes,
of
we
the
have worked
admin
it out.
costs and fees. So there's that, but I think that's kind of important. Okay,
Mhm.
Councilmember Parker.
Yes, we can send that to you.
Okay, coming back to my prepared questions, are there plans to afford the same level of compensation to clinicians employed by CBOs once you bring the program in-house?
We'll have very few CBO clinicians at that point.
I know, but in terms of compensation, will it be comparable to what folk are making now via CBOs?
I don't know if it'll be 120,000 per salary.
Do you have a ballpark? What do you think?
It varies.
It
CBOs
varies,
vary
yeah.
what they're paying people, 60s to 80s. For a licensed clinician starts, I think last year's salary for a 12-1 was like 92,000. So
Depends on their skill.
it depends on their skill and their level of when they're coming in.
And where I'm getting at there is we would want to make sure we're competitive given our workforce challenges. And so if you were going to bring folk in-house and then pay them a subpar wage, I then think that sets us up not to meet our staffing goals.
Again, I can't speak for all of the CBOs, but I believe, lots of the feedback that we hear and the reason why I think there was over 20 people on a CERT is that the salary is competitive.
Okay. Can you explain the differences between the tiers? So tier 1, tier 2, tier 3 that the clinicians engage in? And it's my understanding that the majority of clinicians via CBOs are doing tier 3 work.
So
Or is that not
as
accurate?
you mentioned in the public health model, our expectation in this model is they're providing all clinicians, irregardless of DBH or CBO, are providing prevention, early intervention, and treatment. Prevention are really services that are essentially trying to prevent youth from having more significant problems, right? And so it's things like implementing an evidence-based program like Too Good for Violence, right? And so the individual is going into the classroom and giving an 8 or 10 week curriculum on teaching skills for the entire classroom. Don't necessarily have to have a mental health diagnosis to receive it. Again, we're trying to do preventative work, right? So sometimes it's school-wide, classroom-wide, but we're trying to touch as many youth as possible. Early intervention is a little bit higher. It's targeted to youth who are showing at-risk behavior. So again, who aren't at the level of maybe meeting a behavioral health diagnosis yet, but we're starting to see some behaviors that are concerning. So oftentimes we create small groups for like anger management, bullying, social skills, again, targeted so that we're teaching a specific skill set. Again, it can be, usually 6 to 8 weeks, trying to give them that skill to prevent them from that behavior escalating. And then treatment, of course, is for our students who are in the general education population, but who reach a level of mental health diagnosis or SUD. And so we provide treatment services. Again, obviously, we are very aware that different schools have different needs, right? And so at the beginning of the year, our behavioral health team, which our clinicians are part of, are doing a strengthening work plan, which is essentially a treatment plan of, okay, what services are we going to provide throughout the year? And who on this team, because again, we're one piece of the behavioral health team, who's going to implement what and who's responsible and kind of the timeline.
Understood. So is it fair to say tier 1 is focused on prevention?
Right.
That's
and tier
right.
two
That's more
is-
broad. And tier
Right.
3 is like there's an issue that we're triaging.
Yes, we're seeing an issue and we want to make sure that it doesn't advance so that the child is more severely impacted by
Understood.
that issue.
Understood.
But one of the things I did want to just make sure I was clear about, and that is that our CBOs who are under contract to the Department of Behavioral Health, they actually set the salaries for their clinicians. We don't impose those salaries on them. We give them X amount of money, and from that, they make those decisions. And so the salaries can be in a range across CBOs.
Understood. This is a tangent. The Health Committee recently had a hearing on a bill I introduced, the PrEP Act of DC 2025, trying to expand PrEP access to mitigate rates of HIV and AIDS in the district. One of the things that was intriguing to me in that hearing was the high rates of infection amongst young people, namely, I think it was 13 to 20. I may be wrong on those age ranges, but young people. And one of the responses from DC Health was that they were coordinating with DBH, you all, via the school-based behavioral health program to try to combat some of those rates. While I have you, can you just speak to what that looks like and what that partnership looks like as we're thinking about what additional strategies we might need to employ as a government?
Thank you for that question. Yes, we are. And I'm going to have Dr. Sullivan talk about some of the details. But the goal is that we really want to provide whole person care. And we know that physical health and mental health are all core components in terms of the manner in which a young person can be successful in school and in life. And so we have developed a process where the two teams are really meeting, and we do have a plan to do exactly what you said.
The two teams being DBH, DC Health?
DBH and the school health program.
Got it.
The school-based behavioral health program and the school health program.
Understood.
Right, and so there's a couple of ways that we're collaborating and working because obviously we want to benefit the youth in as many ways as possible. So we are, our school behavioral health staff has met with some of the DC Health staff leadership to create an actual process of being able to collect information, analyzing it, making sure that we're touching youth. And when the nurse or the medical staff, right, sees that there's a need, they know exactly how to refer. Some of the other ways that we're working together is that we're actually doing classroom presentations together. So these youth, right, might be a good way if we know there's a high concentrated area of we could go into that classroom and have what we consider prevention, right, and talk about how do we have a broader conversation about
Understood.
HIV.
For the sake of time, that's really helpful. If I can make a request, I'm really excited to hear you all are saying that. It was staggering to me that I think the stat was 25% of infection rates are in that age range of teenagers. If you could explicitly embed that in your plan to bring this program in-house and how you all will work with whomever across government to really just make sure that's an explicit goal. I think that's going to be really important.
Right, and I think, I've actually written curricula around HIV prevention in another lifetime. And one of the things that's so important, particularly for young people, and it can be down to age 11, whenever someone becomes sexually active, is that they have information around prevention, what to do, if they suspect that something is an issue, how to seek help, and then also the mental health support that they need if they do find that they're positive. So there's a whole range of things that I think are.
I have a minute and 30 seconds. I wanted to come to your timeline for school year 25-26, the current fiscal year. You have a number of goals. I just want to know where you are with these things. So one of award 12 CBO grants to provide behavioral health services. Where are we with that?
They're gone.
They're all awarded. Award 3 LEA grants to provide school behavioral health services directly in their buildings. Okay, contract with an advisor to conduct a case study.
Finalizing it.
And do you have a timeline when that might be finalized?
Went through the process.
Okay.
Through the contracting process.
I'm picking up what you're putting down, as my grandmother would say. Okay, hire 24 new FTEs using existing budget.
We're currently working on that. We're changing some of the program descriptions currently and hope to have them posted.
Hope to have them posted by,
We're posted currently and you're gonna hold me to it. I'm gonna say in the next month, we're working to post them.
and ideally, those folks would be hired by, I know by the end of the fiscal year, but the spring?
Oh, before spring.
I
Okay.
was just thinking of the holiday.
Yeah, before spring.
Okay, great.
Yes,
Okay.
before spring.
59 new FTEs in fiscal year 27 using existing funding.
Right, so we would be, even though 26, 27 will still continue to be a hybrid model, we will be reducing the number of CBOs from currently we have 12 to a maximum of 4. So we will be repurposing those funds that we paid the CBOs at 120,000 per clinician, and we'll be able to hire those 59.
And I imagine that's going to be reflected in the mayor's budget when we receive our budget.
Right, it'll be, the FTEs will shift.
Yes.
Right? There will be, we're not asking for any additional funds.
Okay, a few extra seconds. Strengthen, monitor CBOs for compliance with the performance requirements of the grant and benchmarks.
Okay. And we've included those within the grant requirements that we have already issued. And we will be monitoring those and evaluating the performance according to those specific benchmarks. It's already embedded in their grant that they have.
It's
already
embedded in the
created.
grant.
Well,
Okay.
And similarly to what we talked about before, we created a scorecard. And so every month we will be looking at that
Right.
scorecard and how they're essentially working towards each of those benchmarks. And if there is a challenge, then having TA around what are those challenges? What are the barriers? How can we help support? The other thing that we will be doing is, I think Dr. Bezaron mentioned this, but on-site visits and monitoring.
Are you able to share that scorecard with us?
Sure.
And potentially some of the data that you've collected? I would just be curious to see what you're exploring. Then there's 2 others through, and I think this is self-explanatory, select high-performing CBOs using that scorecard. And then the remaining 8 CBOs, you're going to end the partnership by September 30th of next year. Just very quickly, in maybe 10 seconds, because I'm over time. Like, how are you thinking about transitioning off from those CBOs that you don't move forward with?
Right, so those conversations, similar to kind of the transition plan we talked about before, will need to happen early on prior to summer, so that we can have conversations with the leadership at the schools, laying out this is what's going to happen, here's what the resource allocation is, and this is how it will happen moving forward. And so very collaborative process, and one that we need to be very transparent about so that everybody is on the same page.
Okay, thank you.
That was more than
And thank you, Chairperson Henderson.
Are you all worried about the serious poaching / decimation that could happen to the workforce for some of these CBOs?
Can you repeat that? I'm sorry. What did you say?
You have a lot of CBOs who are currently providing services in schools. They will no longer have these contracts, but you will have positions that are available. But these CBOs still exist in theory. They're not based solely off of the school-based program. I'm just curious, how you all are thinking about the fact that this is going to take a hatchet to some of their workforce.
Yes, and quite frankly, those people from the CBOs, those licensed clinicians, will certainly be able to apply for those roles within the Department of Behavioral Health.
What was your thoughts in response to one of the things that came up around yes, you guys have always had DBH clinicians, but you have been able to be way more picky about who you hire in terms of LSCIW and those who have the independent or higher licensure, as opposed to someone who just recently came out of graduate school and now have their license. Do you feel like DBH is going to have to sort of change their practices a little bit to have more recent graduates now be a part of your program and provide them with the supervision necessary?
And I think Dr. Sullivan can speak to the expansion of the types of mental health professionals also who can work within the program as a piece of that.
I think I don't want to minimize that having a green clinician come through is different than having a well-seasoned clinician. But what I will say is that I think DBH has a few pillars that are they're irregardless of level, right? So our feelings around supervision, our feelings about onboarding. So again, irregardless if you're an LG or an LI, you have like a mentor when you come in. Irregardless, you have weekly supervision. Even if you are an LI who's 20 plus years, right? You still have weekly supervision in the beginning because it is important to help onboard them and provide that support. So not to minimize the differences, but I think the DBH is in a good place to even bring on younger. And we have a few clinicians who are LGs, and we've been able to transition them. And I think we've shared that they took a licensing exam and have now passed. And so I think that our strong components of our program and our pillars help to support those, even the green ones.
Do you guys have interns?
Yes. We do have interns.
How many do you guys take on?
I think we currently have 10.
Okay. I mean, I do have to wonder about the larger piece around the pipeline, right? Not that that is necessarily our sole responsibility, and it certainly isn't, but it is a component. We have been a training ground for a lot of folks who work in the behavioral health space here in DC and in the region by being able to work at the CBOs, get trained, get some supervised experience working in schools. You know, when I think about, even when I'm talking to children's or some of the other folks, right, having someone who wants to focus on like pediatric clinical is, it's getting rarer. Is that rarer? Rare. Yeah. And so I don't want to close that off because we're going to need the pipeline to exist.
That's correct. And we do have an internship program within DBH so that we can help get people in the pipeline, provide them with some experience in schools. And then when they're ready to graduate, those are people who can come into the system. And so I think that's very important. We have relationships with, I believe, 9 different universities now where that are feeders for our internship program.
Okay. And sort of sticking on this workforce question, one of the things that came up was a concern around cultural competency and having clinicians who can meet some of the various needs, even from whether it be identity affirming, language, et cetera. How will you all sort of take that on given the government's limitations in hiring?
Well, first of all, I think we can think about this as meeting the needs of the young person within their environment and their community. And in some instances, it may mean that we might need to have a therapist who can speak their language because their first language isn't English. In other instances, it may be the need to have a therapist who understands their family structure because mom is not the spokesperson for the family and doesn't make the decisions, but dad does. And so if we're bringing them into treatment, we have to make sure that we're aware of that. And so I think that that's one of the reasons why we know that there will be some specialty providers who've done a really good job in that space who will need to continue as we make this transition.
Okay. I feel like that is such a, we obviously have to walk a very fine line. And yet it is so critical and so important. And we see what happens when we don't have that. Like, you know, not your agency, but separate and apart. It was bewildering to me how in our Office of Neighborhood Safety and Engagement, we had violence interrupters, but we had no bilingual violence interrupters at all in the city, which I was like, all right, so y'all are out here in Ward 1 and Ward 4, but like, it creates a gap if it is not addressed. And so I think for you all to be mindful of diversity of workforce is important, period, to meet the needs of
Absolutely.
of the young people. Thinking about workforce still, what training and certification standards will apply to prevention specialists? You know, Miss Aurora had, you know, I thought it was fairly unique in terms of like, this is an opportunity to use some other healthcare workers who may be part-time or, but are good with kids, good with families, and can deliver, if properly trained, to provide some prevention intervention. So what are you guys going to be looking for as the basis of the criteria for this position?
You want to go through the
Sure.
job
So absolutely. I mean, I think we were probably nodding our head when
Mhm.
Chioma was speaking. I think for our prevention specialists, we've added some structure and we're working on the program description. But you know, really looking at bachelor's level individual, not necessarily licensed, obviously, but a background working with children and families, being able to develop relationships, right? Because they might have to go into a classroom and provide prevention, right? So being able to be okay in front of a classroom, so classroom management. But again, so there's pieces that are important to that, but the other piece that I think we want to encourage and mention too is that there's going to be TA and support, right? And so this is a new position and something that we're going to have to support along the way. I think the important piece is that it's not a one, like you have to be this, right? I think we're trying to use this unlicensed position to help and really look at the person and make sure that they're a fit for working in the school behavioral health program.
Yeah.
Right.
Does it have to be a bachelor level individual? And
yes.
I don't want to be a snob about it, but like there are some folks who can be they're community health workers, right? Who have experience in community. They've done other types of work, whether they're working for FEMS, doing peer support or some other thing. They can pass a background check to be around some kids, but like they don't have necessarily the degree. Why do we feel like the degree part is necessary?
We'll follow up.
Yeah.
Okay. I mean, I think that's just something to sort of think about because we do have the community health worker program. Schools are community. Prevention is health. They have a high school diploma, but they may not have a 4-year degree. So just something for us to think about there. I want to ask about the evaluation of success or not. You know, in the plan that I think, or in the documents rather that you've all provided, there are some pieces in there where you talk about some like the performance metrics. And one of the things in terms of the performance metrics that you guys pointed to was implementing evidence-based programs in schools. Now, there's some conflicting pieces there. I don't know if it's conflicting or not, but for some of the CBOs, they said, well, like, you know, sure, we may not be doing the EBP that DBH has written for us, but we have been implementing our own, which according to the contract, we do have an option for, but based on the data that you all are providing here, it's kind of, you're using it as a strike against them if they did not use yours versus their own.
Okay.
Go ahead.
I think within the benchmark.
You have to lean up.
Oh.
I can hear you, but they can't hear you.
Within the benchmarks, obviously there's a prevention and early intervention and treatment benchmark. It requires to implement on a weekly basis. The data that our expectation is that, of course, there are, especially in specific settings, that they can provide homegrown per se kind of intervention for prevention, right? However, we emphasize and we train and we pay for evidence-based models that are curriculum-based, right? So Too Good for Drugs, Too Good for Violence, Signs of Suicide, somebody talked about that one. And so we know that those programs are validated and show good results. And so we want at those evidence-based models to be part of what they're implementing. We also want to be part, kind of the homegrown, like somebody mentioned a truancy group, right? And so those things make sense, right? But at the same time, what we don't want is only one provider only providing treatment, right? And so again, I think our metrics are looking at, yes, they need to implement weekly, and our expectation is that they're using true evidence-based models in addition to some of their homegrown models.
Okay. When's the last time that you guys have looked at the curriculum for these particular models? They could be evidence-based and they can also be stale to these
Right.
2025 children.
Yes, and I agree, and not appropriate to some of our population, right? And so within the plan, one of the components that we talked about is feedback from the clinicians. And some of the feedback from both CBO clinicians and DBH clinicians were that they weren't culturally sensitive, they were outdated, all of the things that you mentioned. So we've taken that feedback. We will be trying to find things that are more appropriate. We have, especially during the summer, we have work groups that actually work on looking at evidence-based models. Are there new things out there? What can we invest in and what can we train people on? So that's an area we know we need to grow and we're open to. So absolutely.
Yeah. I would just say it feels, I could see it from the perspective of a CBO. Whereas you've put out this plan to say, these are all the reasons why we feel like we need to transition. And one of the things you're dinging me on from a performance standpoint is that I'm not using the curriculum that you told me that I didn't have to use. But now you're saying it's important.
Yeah, I want to be clear. The reason why we're transitioning is not just because of performance. We're transitioning to ensure access to all youth, right? And
but you can
so-
see from their perspective, there's now a document that suggests that they haven't been doing what they're supposed to be doing. And some of them may not.
Right.
But some of them who are actively trying to, you have now said, because you didn't do the thing that we have provided to you, even though we told you you could do your own thing, it comes across as though this is a strike.
Understand.
Okay. And I would say also too, in terms of like, I don't know what the cadence is in terms of you all reviewing your evidence-based program material, but I feel like that should be something that's done annually regardless, given, you know, some of it might not be stale or relevant or
100%, we agree. I think, and I think the other thing that we need to do, if they have ideas, right, making sure that there's an open lane for them to communicate that. Because as you know, things come out all the time.
right. But I'm now not just talking about the CBOs because you're saying that you want to transition from them. But if there is an avenue for which your clinicians who are, I'm assuming perhaps maybe not making up their own stuff, but like are using the curriculum, for them to be able to provide that. The individuals who testified today talked about the open feedback portion, but I am curious in terms of how quickly we can sort of turn around on things. Because if we're not bringing in new EBPs every year, it's possible that these things have been stale for quite some time, and we haven't necessarily saw something to sort of transition to meet whatever the particular moment is today.
Also,
you know, EBPs have different.
Right, also the environment changes. And right now, we're in a very different environment than we were a year ago. And so the tools that you're using also have to change so that they can incorporate and address some of those issues that young people are facing because of that. Things like, I mean, we have a new landscape. We have an AI landscape now.
Yeah, we have it, like AI landscape, but you also, I know this from when we were dealing with the little teen takeover situation. They have a whole different language.
That's exactly correct.
That requires deciphering and dictionaries.
Or a young child who can interpret for you.
Yes.
Or a child who can interpret for you.
Yes. You gotta like ask some people who know some people. And in many cases, who I have been asking are like folks who work in schools. Hey, what does this mean? Because
Right.
they're great. They're very quick at it, but they hear what's coming up amongst the kids and are able to sort of rapidly adapt to that. And I think in, Dr. Sullivan, as you're describing what the purpose of some of these EVPs are, whether it be talking about drugs or other types of risky behaviors, et cetera, they come up with new, crazy, risky stuff like every month to try and do. And especially when we think about it from the drug perspective, as you know, from the substance use piece, on the other side of the house, right? Like new drugs or combinations are being introduced. And so we just got to make sure that we're staying up to date on some of that, those things. Just there. Okay, we're coming towards the end here. I just want to ask a couple more questions. So, billing. Now you all sort of distinguish between the billing that happens from DBH and then billing that has happened from CBOs. And frankly, everybody I think is kind of having some sort of difficulty a little bit on that because, and this is something I kind of wanted to bring up from earlier. You mentioned, Dr. Bazaran, like the CBO's limitations on enrolling for treatment. And then my thought was like, is treatment the goal? Might not be the goal.
Well, I think that treatment is a part of the goal. We're looking at the public health model.
Right.
And so
For some kids.
But for some kids, treatment is the goal.
Yes.
If they have that need.
Yes.
Yes.
But what if you have a school community for whom that's not the majority of what those students need?
You provide, that's why we do the school strengthening tool
Mm-hmm.
to determine what the needs are of that population of focus.
Right. But in terms of determining success, you guys also look at billing, no?
We look at billing because, and the reason we looked at billing is because of the model that we have.
Yeah.
It said that the CBOs were to contribute X to the salaries for the clinicians. And so that was,
I see. I'm just sort of thinking about it from the perspective of like,
So
if I have been assigned to a school in Upper Northwest, the combination of whatever the issues are happening up there look very different from if I were assigned to a school in Southwest, for instance. And yet I'm expected to bill just as much as the Southwest person, even though my circumstances look very different in Northwest. Were you all looking at it in that way, or did you have a differentiated look based on what was the student population and the needs of that school in terms of how you all were able to do it? Or do we have a one-size-fit-all? I think we did have a one-size-fit-all model originally.
Yes.
We expected everybody to build the same.
Correct.
Okay.
We did.
All right. So I think we can acknowledge that we're
Absolutely, I acknowledge that.
all right, that we're trying to transition from that part. How, as we sort of transition from this, sort of thinking about the differences of school communities, is DBH going to ensure that resource allocation doesn't inadvertently widen inequities between more resource schools versus under-resourced schools? So I'll give you an example. We've got some DCPS schools where like the PTA is literally paying for multiple staff members. Separate and apart from the DCPS budget, the PTO fundraises for these extra bodies in their building. So you all might say, okay, we don't think that you need a full-time person. And the PTO will say, no, we do. We'll just pay for it ourselves. Have we thought about that part?
Well, I think those are the importance that we talked about before, the collaboration, right? So the landscape was a huge piece in trying to get that data. And so obviously that would change maybe with the PTO, but I think having that one piece, communicating with the leadership, talking with our educational partners who are also connected with that principal and what's going on in that school, then we can make a educated and informed decision about what resources really make sense. And I think as we talked about before, when we're doing it annually and getting that data, we know if things are going to change. Is the PTO going to stop paying for that person, right? Because then their landscape probably
right.
changes, right? And so I think the key is really the collaboration with all the parties, because if you take any piece of that in isolation, you could be missing the big picture. Right?
Yeah. So how are you all thinking about what back office administration for this particular program looks like? Because now we're talking about something much more intense than perhaps what you do now. It's certainly more schools.
Not going to minimize because obviously there needs to be infrastructure and support. And so some of the part of the timeline is shifting some of that and adding. But I'll be honest, these are the conversations and these are the things that the DBH program manager and the supervisors had all along. That's how they were making decisions of, do we need a full-time clinician in this building? And the principal's saying, yes, yes. But then you look at their caseload and they only have 5, right? And they're not getting referrals. And so the supervisors then saying, I'm curious about this, right? And so having those conversations along the way helps to shape what's the resource that they really need, right? And how do we provide that? So, I mean, I'm not going to minimize that. Obviously, this is a big lift and bringing it in-house requires additional infrastructure and support, but that's part of the plan and shifting. And so like we're adding additional supervisors, we're adding additional program managers, monitors, and things like that.
Okay. Will DBH bill students with private insurance for behavioral health services? How will that work?
We do not bill private insurance. We do bill Medicaid.
Okay.
And that's where we are right now. I think that's something to be explored with the insurance commissioner.
Oh, with the insurance commissioner. Okay. Oh, all right. And we're thinking about larger coordination, interagency collaboration. How do you feel like this plan, I guess, involves, coordinates with the plans as you all have re-envisioned the CHAMPS contract?
On the
But one of the reasons, if I recall correctly, and maybe I don't because time is, what is time? But earlier this year when we were talking in the budget process about how you all were rethinking about the CHAMPS contract, one of the things that you all said you felt comfortable sort of pulling back in terms of the CHAMPS funding was because you anticipated that more of the school-based clinicians would pick up on some of the crisis response work. How are you thinking about that now as you're thinking about what essentially would be a new model? Some schools that will only have part-time clinicians, some schools that will have a prevention specialist, which may or may not be able to engage in crisis response. And then some schools for whom it will be telehealth only.
Really good question. And so it's essentially re-envisioning it along the timeline. I think we shared this year. We started providing risk assessment specific training and are requiring obviously our clinicians to provide those risk assessments in the school. However, as we transition, part of our vision, and I think it's in 27, 28, is to essentially have a team who, if there is not a clinician, licensed clinician in that building, they would be able to respond to do the risk assessment. And so we're building in additional crisis services as we bring this model in-house.
Okay, so an additional team separate and apart from
the school-based team.
The school-based team
Right.
that can be called upon.
Yep.
So is that like in-house CHAMPS?
I think she could call it.
In-house CHAMPS Plus.
Okay.
I mean, I think they would do other things. You know, they would, I could hear Erica laughing over here, who oversees some of that work. But I think that in addition, it would not be just time limited, right? They would be doing follow-up and making sure that that youth is connected. There's additional resources. Some of that is done, but obviously with the reduction in staff in CHAMPS, it's not the same level.
So what's your plan B? Let's say you have issues in terms of hiring. I don't know what the I couldn't tell you what the economy gonna look like next week. But let's just say you might have some challenges on that. Is it you would continue with some of the CBO contracts that you have, just sort of as a gap filler, if you will? I guess what I'm trying to get is a commitment that you guys are not going to end the contracts wholesale if you don't have something to backfill.
We want to make sure that if there, for example, let's say that happened, and there were CBOs who are really doing a terrific job, and we could maintain those as we continued our hiring process. Obviously, that's something that we certainly should do, because what we don't want to do is decrease the number of services and supports that are available in the schools.
Okay. Hold on. I wrote down, somebody wanted me to ask you a question, so let me just find it. Give me just a second. There was something about a rubric. I recall, but I don't remember where I wrote it. Oh, yes. Okay. Nicole Travers from the Charter Alliance asked if you guys will allow for feedback on the rubric for determining which schools get what model. And then also if you would allow for an appeals process. Or yeah, I guess a process of reconsideration. So if you all provide an initial determination where we say, we believe that you guys only need a prevention specialist, but the school leader strongly feels like, no, we should have a full-time clinician. What is the process for them to appeal that?
We haven't laid out, honestly, we have not laid out an appeal process. I'm just being very, direct about that. However, our intent is to have that conversation with the school leader about needs, sharing the information that we have, the data we have, and the justification for what our recommendation is. And then certainly we can have that discussion, but we have not developed an appeals.
Okay. And then what about soliciting feedback on the rubric? Like, will it be a formal rubric?
I mean, I think it's going to be a conversation, right? Like, there's no two that are going to be the same, probably. Like, these are the components and the elements that you look at. Like, what's the enrollment of the school? What did the leadership identify as the need, right? And then previously, did the clinician have a full caseload? Are there other providers? So again, I think there's so many pieces of it, and it's taking that data, having a conversation, and then here's the
I think at the very least, you should ask, what do you all feel like are valuable inputs in terms of how we determine what happens next? Because there is certainly fear that it will get too subjective to the point where it's like how it's based on vibes, not based on like the data of like what's actually happening on the ground. And so I feel like you need some sort of guidelines.
Well, and in the environmental scan, we did essentially that. They took all the variables and they dumped them into statistical analysis, and then that they essentially dumped them out into the 4 categories, right? So your school's well supported, it would be a full-time clinician, part-time clinician, but at the same time, we know it's one piece, so we don't just want to use that. So yes, I hear what you're saying, right? Like, and using her word, a rubric, right? Like
Rubrics, guidelines, framework, whatever it is. I'm sure you're going to have some sort of document that is sort of the guiding principles of what are the inputs that you're looking at. And I think what I hear them asking for is, can we get some feedback? Can we provide some feedback on what are the inputs that you're even kind of looking in? Because in some cases, it might not just be what's going on in the school building, but it also might be what does the environment around the school and what is happening, because that is very much part of it as well. What would you say in terms of, Dr. Price earlier testified about like concerns she had with DBH being the sole implementer, the funder, doing the oversight, and doing the compliance, sort of like kind of all in one. Do you all have any hesitations about that at all?
I don't have any hesitations about it, because as we thought this through many years ago, originally this was the plan and the type of framework that we were looking at. I think that we have supervisory levels in place so that we can provide appropriate oversight. Remember, in our city-state kind of framework, DBH provides a lot of direct services, and we have oversight for those, and we're responsible for making sure that quality care is delivered through those. And I see this as being very similar. I do not have hesitation about that.
Okay, hold on 1 second. Okay, Marcia has 2 more questions, but of course they all have 3 parts to them. So here we are. All right. So year after year, students and caregivers, they do come and testify about how they didn't know who their school-based clinician is or what services were available. How do you all plan to address those sort of persistent gaps in communication? That's separate and apart from some of our clinician issues, and communication wasn't sort of mentioned in this plan, but I think it's kind of big.
One of the ways that we've currently been working DC Health and the dashboard, and so we've had some initial conversations with them about creating the dashboard and Link You and adding the school behavioral health information. And so I think that's one way. Again, I don't think there's any one way that's going to solve the problem, right? I mean, we know that. And so I think that our messaging, we have to come at it in different ways. And so I think we've talked a lot about using the youth to be the ambassadors. And I think you spoke about this at some of previous hearings, right? Like they come often and we need to tap into them and use them as our vehicle to get that information and out. So, I mean, I think we're doing a couple of things. Obviously, we're working on the tangible thing of the dashboard and making sure that the information for each school is there, but then also really using youth and families to help share the information.
I really am a big supporter. You don't even have to reinvent the wheel. Earlier this week, they swore in like the youth government here, right? So you got some youth mayors and council members and at-large folks and whatnot. They're all high school students. They all go to DC schools and they all have networks. And they all desperately want the opportunity to be able to contribute and serve. The same could be said for the student members of the school board who similarly have like followings, kind of using them. But I do feel like, and I shared this with you before, right? My apprehension around sort of the telehealth in the high school space, it only works in so much as the kids even know that that is an available option for them. And so how we communicate that to them, how we build that trust, that is something that I feel like needs to be a part of the plan. I don't know how you do that when you don't have a DBH clinician in the building to be the responsible person for that. But, a lot of the DCPS schools, they all have wellness teams. And so this is an additional tool that could be available to support those folks. And we just kind of have to think through that.
Well, and as you know, each school has a behavioral health coordinator. So maybe we can link it through there.
Yeah. Okay. And then let's see. Okay. The plan states that DBH intends to contract with an expert to conduct a case study evaluation of high-performing CBOs to identify effective practices. At the same time, the plan is very sort of definitive in terms of we're going to move away from using CBOs. So what's the timeline on contracting with the evaluator, and why do you all still feel like that is an important move?
I think the goal is, if there are best practices, we want to look at, first of all, what we're doing and what's working really, really well and where our pitfalls are so that we can avoid them. And so doing those case studies will give us some of that information. And we have reached out to several experts in school-based behavioral health to get their feedback, because, we wanted to make sure it was kind of outside of the system, giving us that input. And so I think that will be helpful, particularly as we're moving through the refinement of this planning process.
Okay. So what's the timeline for contracting with the evaluator?
We were trying to do it quickly, but as soon as we can, that's what I'll say.
Okay, well, when you all have the findings on that, please.
Okay, we'll let you know.
We would definitely be interested to sort of
Okay.
hear back some of that,
Okay.
that feedback there. I think that's all that I have at the moment. Is there anything you wanted to share that I haven't asked? Or that Councilmember Parker hasn't asked?
Well, I would just like to say we're really excited in terms of, we've looked at various options. We think that we have a plan that would at least allow us to meet the goal of making school-based behavioral health accessible to all young people, and that we want to work with all of our publics and all of the parts of the community as we refine this moving forward. So.
Yeah. Well, so this concludes our roundtable today on DBH's comprehensive plan for the school-based behavioral health program. I want to thank everybody who joined us today. I think your insights were invaluable as we evaluate this major shift in how school-based behavioral health services will be delivered. I think I mentioned earlier, this wasn't designed as a mechanism for the council to reject a plan versus not. I guess our formal opportunity to reject would be during the budget, as that kind of sort of drives things. But our real North Star here was like, how do we expand access? Because it was very gnawing that it seemed as though we hit a ceiling in terms of the number of schools that we were able to serve. And I don't feel like there was necessarily some fairness in that, because we definitely had some students who were very much in need, but we could not meet those needs based on the current model. So I'm open to us exploring what new models can look like. I do wish that you all had been more engagement oriented in terms of taking in new ideas as you sort of created this plan. But I think that is going to speak to what happens next and how we have engagement with stakeholders and conversations, because a lot of your CBO partners who have been in the trenches with you from the very beginning, right? Even, in the early 2000s and otherwise, when they were providing support, when you guys didn't have a full program stood up, I think are probably feeling very devalued as you start to transition. And it may not even be the transition part that is really gnawing them, but it is the way in which it has happened. And so we gotta have to amend some. Y'all are gonna have to do some of that outreach and engagement work. I think what we heard today underscores the urgency, though, as well as the complexity and what it takes to strengthen our school-based behavioral health system, especially when we're talking about so many schools. And I don't think that people necessarily appreciate how many public schools actually operate in the district. And so this is going to be a shift. This is definitely going to be a shift in terms of how services are delivered, but the goal of consistency and accountability and equity are commendable, and I appreciate you guys centering and focusing on that. So written testimony will be accepted through Wednesday, November 19th at 5 p.m. If you weren't able to testify today, you can submit your written testimony at dccouncil.gov/hearings. We will be back tomorrow with the Department of Behavioral Health in a different room. We'll be back at 11. We'll be in room 412 for a joint hearing with the Committee on Human Services on the permanent supportive housing programs. But the time is 2:43, and this roundtable is adjourned. Thank you, everyone, for participating.
Thank you. Whew.